بسم الله الرحمن الرحيم والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. أعزائي أبنائي إخواني الطلبة، يتجدد بكم اللقاء في محاضرة جديدة من سلسلة محاضرات Ophthalmology Made Easy. Our lecture for today is very important as it contains summarize for all what we have spoken before regarding different corneal diseases. And this lecture is primarily oriented for those candidates who are willing to appear for the any postgraduate examination like the Libyan board or the FRCS examinations. It contains one of the most challenging 25 problem-solving questions with the detailed answers and reasoning for these answers, and a comprehensive review for all what we have mentioned before in different sectors of the corneal diseases, starting from the simple corneal diseases and corneal infections, ending up with the keratoplasty and the cross-linking and keratoconus and other topics. So this is a very important lecture. I would like to concentrate in this lecture and you train yourself how to deal with the problem-solving questions that you are going to face in the FRCS exam or in the oral exam in front of your examiners. I hope for you the best of luck and looking forward to meet you in another sessions, and let's dive deeply and see what's inside this lecture. This is a case scenario of a patient with keratoconus, as very evident by the pentacam picture and the Pellin-Ambroso display. Very clear increase in the curvature in the inferior part as compared to the superior part in the curvature map, and it decreased thickness of the cornea 343, and in the anterior elevation map there is no much obvious changes. However, in the posterior elevation map a clear-cut central nipple cone is present, which is very evident by the enhanced reference surface, as you can see in the Pellin-Ambroso display. This posterior elevation is very evident, also the anterior elevations, and this is the subtraction map that shows clearly the difference between these two maps. Also, when you look to the bachymetry display and the bachymetric progression, very clear deviation from the normal in the percentage of bachymetry changes from the central point to the periphery up to the 8 millimeter zone. So this is a very definite clear-cut case of advanced keratoconus. Why we say advanced keratoconus? Because the Kmax is more than 61 diopter, and also the bachymetry is less than 400, so around 343. So this patient needs special attention and care in the management. So to summarize the finding, there is severe corneal thinning with extreme steepening and significant elevation abnormalities, as evident by the Pellin-Ambroso display. The total deviation, as you can see here, which is denoted by the red color. So all the parameters of the Pellin-Ambroso display on the anterior elevation changes and posterior elevation changes, and the bachymetry and the thickness at the thinnest point and the deviation along the y-axis all are in red color. So this indicates significant deviation. That's why the overall standard deviation of this map is 7, which is much more beyond the normal value. So now we will discuss how to manage such a case in view of this data. First of all, this patient needs detailed or precise optical management that's in the form of contact lenses, whether he is tolerant to the rigid gas permeable contact lenses or not. Most likely glasses will not be helpful in these patients. As far as the cross-linking, this patient is not good candidate for cross-linking unless we use special protocol for thin corneas, because he's around less than 400 micrometer. So we have to use the sub 400 protocols or other protocols for thin corneas that I will explain about them later on. Also, he's not a good candidate for intracorneal rings because of the same reason, the high K reading as well as the thin cornea. K reading more than 60 is a contraindication for intracorneal rings, and very thin cornea less than 400 is also another contraindication for intracorneal rings. We will discuss also later about the contraindication of the intracorneal rings from my lecture on intracorneal rings. So this patient is either we have to use contact lenses. If he is not tolerant and he is looking for other options, we can go for DALC procedure, provided he has intact dismal membrane and there is no fibrosis in the cornea, and this should be done by the help of OCT to determine the intact dismal membrane and no stromal haziness. Or we can, if so, there is scarring in the cornea and there is damaged dismal membrane, we will go for penetrating keratoplasty. So the corneal thickness of less than 400 micrometer is contraindication for corneal cross-linking. Now, as far as the protocols or the management for thin corneas, we have different protocols, as I have explained in the lecture of the corneal cross-linking, that we can use the hypoosmolar riboflavin to swell the cornea. However, there is some disadvantages of this protocol, that the efficacy is limited and there is unexpected result from these values. Also, we can use the contact lens enhanced CXL, where we use a special ultraviolet permissible contact lens to compensate for the decrease in the thickness of the cornea. Also, we can use the transepithelial AB-on protocol, but even the transepithelial for this patient will not be enough because he already has 343 micrometer. The last thing that we can use the back CXL, which is the bachymetry assisted customized AB-on cross-linking. This is most likely will be useful in this patient because we will deliver the energy fluence based on the thickness of the cornea, so will not damage the corneal endothelium. So as we used to say that the management of keratoconus based on 3 levels, we have to improve the visual function of the patient, and we have to improve the topography of the patient, and we have to secure the stability of the patients. So the first step in the management is the stability by cross-linking, and then we will improve the shape of the cornea either by the use of intracorneal rings or by use laser like topography guided treatment, and finally fine-tuning of the visual function also by laser or by other means to improve the visual functions. So this is how we improve the topography intracorneal rings by tissue LA or topography guided PRK or keratoplasty. And as I said, all of this should be done on the top of improving the stability. That's the cross-linking. Now, when we look to the contraindications for intracorneal rings, as I have explained in my lecture about the intracorneal rings, the contraindication for advanced keratoconus with severe thinning less than 400, or with corneal scarring, where there is opacity or bogus stria, also hydrops with corneal fibrosis. This is contraindication for intracorneal rings, or the presence of any active corneal disease, autoimmune disease, pregnancy, and unrealistic patient that is looking for high expectation. All these are contraindication for intracorneal rings, as evident from the lecture that I explained before. This is another case scenario for a patient who is complaining of fogging of his vision, especially in the morning, and gets clear up a little bit when the day goes on. So this is very important point in the history, fogging in the morning, which gets improved after some time. With on examination shows bilateral corneal gut theta and mild stromal edema. Bachymetry is very high. You can see 650 microns bachymetry in the right eye and 630 in the left eye. And the examination by specular microscopy, as you can see here, there is significant defect in the endothelial cells of this patient, and this is corneal edema, as you can see by slit lamp with honeycomb appearance of the with cyst formation in the corneal epithelium. So according to this finding, what's the diagnosis? Of course, this is a diagnosis of Fox endothelial corneal dystrophy or endothelial problem due to Fox endothelial dystrophy. Now describe the findings in the specular microscopy and what are the indications for the surgical intervention for this slide. Now we will open the discussion for the answer of this scenario. As you can see from the scenario and from the history, that the patient suffer of worsening of his vision and waking up in the morning and gets clear up for a little bit when the time goes on, and this is a very peculiar history, especially for Fox endothelial corneal dystrophy. Now, Fox endothelial corneal dystrophy is a disease that predominantly affects the corneal endothelium, And as you know, the corneal endothelium is the main structure that's responsible for the corneal detrusions. And by specular microscopy, we can document the reduction in the number of the corneal endothelium. However, we shouldn't just only depend on the corneal endothelial cell density to assess the function of the corneal endothelium, because as you can see here, in the presence of plenty of corneal guttae, we cannot accurately estimate the corneal cell density. For example, in this rectangle, you can see the endothelial cell density is 893. In the same cornea with another area, you can see the endothelial cell count reaches up to 2,200 per millimeter square, and in this area another figure. And what I want to say that in the presence of multiple confluent guttae of the cornea, the corneal endothelia will be masked, and we cannot accurately estimate the endothelial cell density. So we have to use a manual way. Don't just depend on the automatic way of the machine to estimate the corneal endothelial cell, but we have to measure manually different areas of the cornea so that we can reach to the approximate number of the endothelial cell density. Another thing that there are other parameters that is important in the assessing of the endothelial cell function apart from the endothelial cell density is what's known as the polymegathism. The polymegathism, when we found that the coefficient of variation is more than 30%, this is indication of variation in the cell size of the endothelium, and this is named as polymegathism. Normally, we should have a figure less than 30%. More than 40% indicate that there is polymegathism. And also the presence of hexagonality. Normally, we have more than 50% of hexagonal cells of the endothelium. If the percentage of hexagonality is less than 50%, this indicates that we have pleomorphism, which is variation in the cell shape. So by definition, guttae means this is the noun. This is the plural of multiple small spots in the corneal endothelium. Histologically, it is a wart-like extension from the Descemet's membrane that is form and mask the appearance of the corneal endothelium. So when we say that corneal guttae, it means that we are sure that this is case of Fox endothelial corneal dystrophy. However, when there is multiple small lesions in the corneal endothelium that is resembling the guttae, at that time we say corneal guttata. Now, corneal guttata means it is a spot-like. It is not confirmed, but it is a spot-like. It can be corneal guttae due to Fox endothelial corneal dystrophy, or it could be something else. So we should be very precise in our terminology. The guttae is the noun and it is the plural form. This is the plural form of this pathology, so that when we say that this is corneal guttae, we means this is case of Fox endothelial dystrophy. However, when we are describing multiple spot-like lesions in the corneal endothelium resembling the guttae, so we will say this is guttata shape. When we say guttata shape, this is the adjectives of this noun, so we are not sure that this is Fox endothelial dystrophy. So this should be very clear for you as a postgraduate student. Another thing that I advise you to carefully practice the way of specular reflection and to know the principle of the slit lamp examination using the specular reflection, because this is one of the descriptive or the important clinical tools that you utilize to describe the corneal endothelium using the slit lamp. So specular reflections, the principles that you utilize is that the incidence of the angle of incidence equal to the angle of the reflection, and we are monocularly, we can see the reflected rays, so we focus the light on the structure that we want to see, and by high magnification, this is very important, we cannot see the endothelium with low magnifications. We have to use the 40x magnification to see the corneal mosaic shape of the corneal endothelium, as you can see here. And this is called specular reflection. The examiner might ask you how to demonstrate the corneal specular reflection. You can see here, this is the very nice the mosaic pattern of the corneal endothelium, and don't be surprised that this is seen by the slit lamp. This is just seen by the slit lamp. Similarly here, you can see with the illumination, this is the prior to illumination, the anterior surface, and this is the mosaic pattern of the corneal endothelium. So you should be prepared to be asked about the specular reflection when you are discussing a case regarding the endothelial cell function. So I advise you to go and read carefully about this technique, and you should be able to practice this way and demonstrate it in front of your examiner. Still in the context of Fox endothelial corneal dystrophy, there are a set of different questions that you should be prepared to answer them, as the examiner might ask you in this subject regarding these things. Now, the first question, does all types of Fox endothelial corneal dystrophy require surgical intervention? And what about what's meant by endothelial injection therapy or ex vivo endothelial culture? Now, the other question, is it true that lower endothelial cell density is associated with lower endothelial cell function? And you should explain this in details. Now, I will start with the first question, that does all types of Fox endothelial Fox endothelial cell dystrophy require surgical intervention? The answer is not, because previously we were based on the penetrating keratoplasty as the main stay of treating endothelial Fox endothelial corneal dystrophy, and we rely on the pachymetry. Once there is documented very thick cornea and marked drop in the vision, we do penetrating keratoplasty. However, now with the advancement in the techniques of endothelial keratoplasty, the penetrating keratoplasty has been surpassed by different iterations like the DSAC, DMAC, and recently the DISO, so that there are certain indications for each type of these procedures. However, early intervention is indicated to avoid persistent chronic complications in the form of fibrosis of the cornea and fibrosis of the stroma due to long-standing corneal edema and other associated complications like recurrent corneal erosions and so on. However, there is a new term emerging which is known as the subclinical edema. Now, the presence of subclinical edema is indicated for surgical interventions, and by subclinical we mean that it is not seen clinically by slit lamp, or you find corneal haze or folds in the Dismus membrane, but you can determine it by tomography only. There are certain criteria. First of all, there will be loss of what's known as loss of the regular corneal isobax. Normally, the cornea has a regular concentric transition of the thickness from the thinnest point toward the periphery, and this is seen by tomography clearly. This stepwise transition is normal. However, in patients with Fox endothelial corneal dystrophy with subclinical edema, they will have loss of this normal transition, so that you will find large steps between the thinnest point to the thickest points. Another point that suggests of subclinical edema is the displacement of the thinnest point. You know, the thinnest point of the cornea usually coincides with the corneal vortex and usually present in the just mild inferionasally. However, in the presence of Fox endothelial dystrophy, they will find the displacement of the thinnest point. You will find it superiorly or somewhere else. Another thing, you will find focal posterior depression, the posterior surface of the cornea due to the corneal edema. It will sag into the anterior chamber. So in the elevation map, you will find a negative elevations in microns. It's suggestive of sagging of the posterior surface of the cornea that becomes more steeper and more oblate in shape. And this is very important point that we will discuss about later on when we plan for triple DMAC, that you want to do DMAC along with cataract surgery. So this important point that might lead to refractive surprises in the IOL calculations. So you can see in this corneal topography, this patient has the normal corneal isobax, but he has displacement of the thinnest point of the cornea that's present superiorly, and also he has negative points here that's suggestive of sagging of the posterior surface of the cornea. So this is subclinical corneal edema, and this is indication for surgical intervention. Now, as far as the second question, the meaning of endothelial cell culture or cell therapy, that the ex vivo endothelial cell culture injection is a cutting edge and still experimental and minimally invasive techniques for endothelial cell transplantations. And initial result shows a very promising result in treating endothelial disorders. And this can revolutionize the corneal care and overcome the donor shortage and reducing the complications of the SAC and DMAC. So this technique is still under experimental levels, but initial animal experiments have shown very promising result. And this type of therapy is combined with what's known as ROC inhibitors, which are drugs that blocks the action of the enzyme Ryu associated protein kinase. This is important, plays important role in cell migration movement adhesions. So the combination of this technology along with the injection of the endothelial cells is promising in replacing the traditional type of surgical interventions. Now, the third question, is it true that the lower endothelial cell density is always associated with worse endothelial cell function? Also, this is the answer for this is no. Because, as I said, the endothelial cell density most of the time is not reliable, especially in the presence of confluent gut data, so that the machine will not calculate the endothelial cells which is masked by the confluent gut data. So it will give you a low endothelial cell density in spite of the normal endothelial cell function. So always don't just rely on one parameter to assess the endothelial function, but you need other different parameters as the polymorphism and polymegathism and the coefficient of variations. All these parameters are very important in determining the cell function. Now, this is another example of a case of subclinical corneal edema that indicate that the patient needs surgical intervention. You can see here there is loss of the normal corneal isobax, and there is large step transition between the thinnest point to the thickest point. Also, the negative depression, as you can see here in the posterior elevation map. So this indicates sagging of the posterior surface of the cornea, and the displacement of the thinnest point. So this indicates subclinical edema. And as you can see here in this specular microscopy, although the corneal density is good in both eyes, and also the coefficient of variation is below 30%, which is good. However, when you look to the hexagonality in the left eye is okay, more than 50%. However, in the other eye, it is less than 50%. So this is indicate polymorphism. And we shouldn't rely only on one parameter, although this cell count is high, but the hexagonality is low. So indicate that there is stress and compromise of the corneal endothelial function. This is another case scenario of a 32 years old patient using a soft contact lens, presented with intense pain and photophobia with decrease of vision in the right eye. As you can see, the slit lamp finding shows this is the ring infiltrate occupying the central part of the cornea with overlying epithelial defect, and this is the picture of the diagnostic for this pathogen, which is the radial keratoneuritis. This is pathognomonic for acanthamoeba keratitis. So this is common case that's come in the exam, but the important thing regarding the discussion, usually the diagnosis is not difficult, spot diagnosis. However, the discussion is very important in these cases. So what's the spot diagnosis? This is case of acanthamoeba keratitis. Now we will discuss the details regarding the complications and the management of this case in the next slide. As you know, as I said, that the diagnosis is acanthamoeba keratitis, which is a free-living organism that is present anywhere in the salt water, in the soft water, also in the soil and in the air, and even as a commensal organism inside the mouth of the body. So acanthamoeba is a freely living organism commonly seen in patients who underwent trauma with a vegetative organ, or patients who are on long use of contact lenses, using the soft contact lenses, and also in people who are immune incompetent. So in patients who are immune incompetent, they may suffer from other manifestations like lung infection and brain infections. Now, the complication of these cases, if not treated well, the risk of corneal melting is very high, corneal melting, and spread to the adjacent structure that's causing severe scleritis and also super added bacterial or fungal infection. Now, the hallmark of this disease that it has insidious course that's within 7 to 10 days, but the patient presents with severe pain. Now, this severe pain is disproportionate to the clinical signs and symptoms, and this is very important that you find a severe pain in the patients, and you will find just mild congestion in the eye, and there is no corneal infiltrate. This is in contrary to the fungal infection, in which you find a very minimum pain in the patient, but you will find when you examine the patient with the slit lamp, you will find a significant finding with severe abscess formation and hypopyon formation, but the patient complain of mild pain. This is one of the differential points between acanthamoeba keratitis and fungal keratitis. So one of the main features of acanthamoeba keratitis is the pain. The pain is known as ophthalmodynia, which is out of proportion to the clinical signs. And when the disease progresses, it will end up with catastrophic complications like corneal melting, abscess formations, and scleritis. But initially, you will find severe pain with minimum clinical finding. Now, when we speak about the investigation of these patients, of course, the top, as usually say in any infectious keratitis, is the corneal scraping. The corneal scraping is the gold standard for the diagnosis of such infections, especially from the cornea itself, from the contact lens itself, or from the solutions. Then we come to the confocal microscopy, if it is available. Of course, this is expensive and is not available in most of the hospitals. The other thing is corneal biopsy is very important also for the confirmation of diagnosis of acanthamoeba keratitis. And finally is the use of PCR. PCR is very specific and sensitive for picking up acanthamoeba keratitis. So if we want to grow this crepe, we will grow it in nutrient agar with E. coli overlay, or we can use there is special stains also like the cauliflower white, methamine silver, and periodic acid shift stains. For example, you can see here, this is the cyst for the periodic acid shift stain. You know that the acanthamoeba present in two forms, either in the cyst form or the trophozoite form. The cyst usually a polygonal in shape. This is the cyst. And this is the spikes of the trophozoite form. This is stained with methamine silver, and this is the fluorescence seen by cauliflower white. So this is the special stains used for the staining of the acanthamoeba, and when we grow it in non-nutrient agar with the E. coli overlay. Now the initial management, of course, is immediately, and we have different classes of drugs that can be used, like the cationic biguanides. In the top is chlorhexidine and polyhexamethamine biguanides, or the imidazole group, that's the ketoconazole, fluconazole, meconazole. But usually the first line monotherapy or double therapy is the use of biguanides, and we use the imidazole groups as adjuvant therapy. Now, another important question that you might be asked by the examiner: what's the role of steroids in these cases? Now, it is totally prohibited to initially start with the steroids in any such cases without the confirmation of the diagnosis. And also, if you confirm the diagnosis of acanthamoeba keratitis, it is not, absolutely contraindicated to use it as a first-line treatment, and especially for the first 2 weeks after the initiation of anti-acanthamoeba treatment, till you are sure from frequent corneal scrape and by confocal microscopy that there is no active inflammation, no active trophozoites are present. You can use a steroid at that time to minimize the inflammation and reduce especially the pain. Now, the aim of this steroid use is to minimize the pain. So because the pain is due to radial keratoneuritis, due to a cell-mediated immunity, so the use of steroids will relieve the pain in such case. But this is applied once you are confirmed there is no active trophozoites by corneal scraping or by confocal microscopy or corneal biopsy. So this is very important. So there is no absolute contraindication for steroids, but it is contraindicated to start with it initially. Now, I shouldn't forget about one of the important drugs that I have mentioned in my lecture before. That's the miltefosine drug, which is an anti-leishmania drug, which is used found to have an effect against Leishmania as well as against the trophozoite of the acanthamoeba. It is given as an oral medication, but it is not used as first line of drug. It is used as adjuvant therapy along with the chlorhexidine or polyhexamethyl biguanides. So this is in brief the important points about the acanthamoeba keratitis. The answer for the other questions, that's the Teo et al. Grading system of acanthamoeba keratitis, is a clinical grading system based on 3 stages on the extent of the corneal involvement and is associated with the clinical features. So this is a clinical classification based on the slit lamp examination and some advanced laboratory investigations. Primarily observed through the slit lamp examination and supported by the diagnostic tools like the in vivo confocal microscopy and the corneal scraping and the PCR. So the stage 1 is just an epitheliitis and described as early stage of the disease in which the infection is still limited to the epithelium and characterized by diffuse punctate epithelial irregularities with microcystis or edema or pseudodendrites with no or minimal stromal involvement, and mainly the patient will complain of mild pain, foreign body sensation and photophobia and tearing. This stage is difficult to pick up at this stage because it is very early, and actually this stage carries a very good prognosis because if diagnosed at this stage and you start immediately the anti-acanthamoeba treatment in the form of biguanides and diamidines, the prognosis will be very good. Now the second stage in which there is extension beyond the epithelium, which is the stromal involvement. So in this stage the disease progresses to involve the stroma, sometimes with or without epithelial involvement. So the feature characterized by radial keratoneuritis, which is pathognomonic, caused by the amoeba invasion along the corneal nerves. This is a pathognomonic sign for acanthamoeba keratitis. Also the presence of ring infiltrate, which can be seen up to 50 to 60% of the cases only, indicating stromal involvement, and apart from the stromal haze and edema. The feature of this stage that the pain out of proportion to the clinical signs, and the patient will sustain of severe pain with reduced visual acuity and also to some extent photophobia. The diagnosis of this stage is mainly based on the in vivo confocal microscopy, which shows the hyperreflective cystis in the stroma, and also on the PCR, which confirmed the presence of the DNA for acanthamoeba, and of course by the use also of the culture. The prognosis is not that good as the first stage because it is challenging, and the treatment due to the location of the cyst deeper in the stroma, so the treatment will not reach in a proper concentration, and you need a prolonged therapy, especially in the presence of a large load of cystis which resist the treatment. The third stage, which is the advanced disease with complications, include severe superadded infections, and cornea becomes severely extensively melting, and potential for extracorneal involvement, especially the keratoscleral involvement. So in this patient there will be a full thickness involvement of the cornea, and with ulceration and thinning and ring abscess and melting of the cornea. Secondary complications, as I said, like scleritis, anterior uveitis, hypopyon, and patient will complain of severe pain and significant loss of vision with systemic symptoms like the fever and malaise, and the patient will be sick. Now the diagnosis in this stage also, as I said, confirmed based on the in vivo confocal microscopy and the use of PCR, but also corneal biopsy may be required in refractory cases. Sometimes because of the heavy load and severe inflammation, the detection of the cystis inside the cornea will be difficult, so you might need to do a corneal biopsy to confirm the diagnosis. And also this classification is important for the management of the case, so that most of the cases, if picked up in stage 1, is amenable for medical treatment, and patient can be treated with just the biguanides and diamidines. And if patient at the stage 2, the combination therapy along with the adjuvant therapy, especially steroids, although this is controversial, the suggestion that after corneal biopsy and after scraping, if there is no cystis and trophozoites, you can use steroids at that stage. But patient with the third stage, they require surgical intervention in the form of lamellar or penetrating keratoplasty. And even though there is a high risk of failure of the graft in this stage. So this is the Theo-Etol grading system. You should be aware of it. It is just a clinical staging system that will guide the management priority of the patients, and you know your patient at what stage is he, in the mild early stage or in the severe advanced stage. Now we come to the pharmacological therapy or the management of the acanthamoeba keratitis. As I said earlier, the early diagnosis is very important and has a better prognosis, because if you pick up the organism just in the epithelial level, that's no more penetration to the stroma, so the drug concentration will be very effective, and at that time you can secure and guarantee cysticidal and trophocidal effect of your medications. However, if the drug is already penetrated to the stroma, the eradication of the organism will be difficult. And before all of this, a high index of suspicion is very important and is of paramount importance in management of acanthamoeba keratitis, that you should think of acanthamoeba in each and every case of contact lens, using a contact lens. The most common combination in the medical field for the treatment of acanthamoeba keratitis, what's known as the dual biguanide therapy. That's the combination of topical biguanides and diamidines. Biguanides in the form of polyhexamethylene biguanides, and the diamidines or the aromatic diamidines, that's the probamidine, commercially known as the proline. So this is the most common combination. Why? Because the biguanides mainly act as a cysticidal. However, the diamidines act as a trophocidal with minimum cystatic effect. So this combination, you can guarantee both the cysticidal effect as well as the trophozoicidal effect. Now, in the field of the acanthamoeba management, there are some other novel agents that's emerging, like the imidazoline salts and silver nanoparticles. They shows some cysticidal and trophozoicidal activity, and the initial results are promising. Another second line of treatment is the miltefosine. This miltefosine is either topical or systemic. Initially and primarily it is an anti-leishmania treatment, but it shows an effect against amoeba, so it is one of the second line used for reluctant cases. Now, as far as the use of steroids, there is a controversial, but it should not be used as a monotherapy. At least 2 to 3 weeks after the use of this combination of biguanides and diamidines, you can use steroids if there is severe inflammation, so that you want to reduce the inflammation, and especially if there is keratoneuritis or keratoperineuritis, so you can use steroids. So some rare applications or medication used, like the use of photodynamic therapy, the use of Rosbengal based on the photodynamic therapy, or the use of intrastromal injections of varicocele and biguanides has been also tried. Also, the use of Paxi-XL in the treatment of acanthamoeba keratitis also has been used, but the most famous and the classical treatment is the combination of biguanides and diamidines. Of course, for the surgical treatment, if all this failed and there is endangering the vision of the patients, you can go for lamellar keratoplasty or therapeutic penetrating keratoplasty for such cases to avoid further complications. This case scenario appears very simple, and this is a 30 years old patient who presented with unilateral eye pain, redness, and tearing. On examination, you can see with the fluorescein staining reveals findings suggestive of branching dendritic ulcers, and this is staining with Rosbengal and fluorescein. As you can see, the base of the ulcer is stained with the edges of the ulcer is stained with Rosbengal, and the other parts of the ulcer is stained with the fluorescein. The one which has desequamation of the epithelium is stained with fluorescein, and those virally infected cells are stained with Rosbengal. So the diagnosis, I think, is very simple. Even a fourth-year student can answer this question, but you should be prepared for other way of discussion regarding the management, as well as the difference between fluorescein and rose bengal, and about the pathogenesis of the dendritic ulcers. And now the next discussion will be about the management of the case and what are the medications and the controversies between the use of oral antiviral, topical antiviral, the use of steroids, and so on. Now, after we know the diagnosis is simple, that this is epithelial keratitis due to herpes simplex. Now, the management, you should answer the management properly and should be prepared for any questions, especially regarding the herpetic eye disease study, the first trial, second trial, and third trial. Now the management for active epithelial multiplication of the virus in epithelial keratitis is usually due to by the use of topical antiviral, or some doctors now the new trend is to use the oral antiviral instead of the topical antiviral. Now, first of all, let's speak about the topical antiviral. The most common, especially which is available in the United States, is the ganciclovir and the valciclovir. Acyclovir per se is not FDA approved. So although it is used worldwide and receives general acceptance by most of the doctors, but it's still not FDA approved. However, valciclovir and famciclovir is commonly used, especially ganciclovir as a topical medications. Now, they found that the use of oral antiviral is also effective in epithelial keratitis because they found the level of this drug after oral application in the aqueous and as well as in the tear film is high, and it has given a good effect as the topical medications, and it acquires special care, especially in those patients who you are willing to use more than topical medication. For example, you want to use antibiotics, you want to use mydriatics, sometimes you want to use steroids for any other indications. So at that time, oral antiviral is preferable. However, as I said, for topical steroids is prohibited and contraindicated in the presence of active proliferation of the virus in the dendritic ulcers. Now, the indication of steroids in herpes simplex is a special subject. And just briefly, I will mention the indication in the presence of interstitial keratitis or in the presence of iridocyclitis. At that time, you can use steroids. Another indications for the use of oral antiviral, apart from the epithelial keratitis, is in the presence of acute or necrotizing stromal keratitis, also in the presence of endotheliitis or presence of iridocyclitis, and all these are the recommendation from the herpetic eye disease study or the herpetic eye disease trials. So you should understand what are the indication of use of steroids. You should understand the indication of use of oral antiviral and the contraindication of steroids and so on. This is very important. Among the indication of oral antiviral is also in infants and immunocompromised patients and a single-eyed patients. All these people, you should use oral antiviral as a prophylaxis for recurrence, as well as especially if there is patient with stromal keratitis, the chance of recurrence is high. So you should use oral antiviral and not just use topical antiviral. So you should be prepared for such type of questions. Not just only you know the diagnosis is you have done the job, no, but you should be aware of the herpetic eye disease trial, type 1, type 2, type 3, one regarding the topical use of or the role of steroids in herpes simplex keratitis, and the role of oral antiviral, and the role of oral antiviral in the presence of iridocyclitis. This is another case scenario of a 58 years old patient who underwent Dismeth's ribbing automated endothelial keratoplasty, that's DSAC, 6 months ago, and now presented with sudden onset of blurring of vision, pain, redness, and in the operated eye. Now you can see this is the picture of the OCT for this patient, corneal OCT, and you can see this is the DSAC. That's the Dismeth's membrane along with a part of the stroma done by automated way. So this is very clear that the graft is not detached and is well co-opted to the stromal bed. Now, when you see to this picture, you can see clearly that there is fine keratic precipitates and there is corda dust lines. So this is the beginning of endothelial rejection. So this is a case of post-DSAC rejection. So this is the diagnosis. Now we will discuss about the signs and symptoms and how to manage this case. As I said, that this is a post-DSAC graft rejection, and as demonstrated by the presence of keratic precipitates and inflammatory cells, and also clouding of the cornea and corneal edema, and this is why the patient complains of blurring of vision. Now, this is one of the ocular emergencies that should be immediately dealt once confirmed the diagnosis, and you find the reaction in the anterior chamber and the keratic precipitates. We should start immediately with topical steroids and also systemic steroids with intensive treatment so that we can co-opt this attack and this rejection. Now, for those who don't know the difference between the DSAC and the DMAC, you should know about this. The DSAC, in which we strip the desmoid, the endothelium along with the desmoid membrane and part of the stroma. However, the DMAC is very thin membrane. That's we remove just the endothelium and the desmoid membrane with minimum, if ever, part of the stroma. So this is a very thin membrane. However, the DSAC is a little bit more thicker because part of the stroma is involved. This is the difference between the DSAC and the DMAC, and this is the gold standard now for the treatment of any endothelial dysfunction like bullous keratopathies or any damage to the endothelium like Fox endothelial dystrophy. So this is the gold standard for these types of treatment, provided certain indications that there is no stromal fibrosis. Another interesting case scenario, which is also related to the cornea, a patient who is 7 years old brought to the ophthalmology clinic with his parents, and they notice a white yellowish mass at the edge of the left eye since birth. The lesion has remained stable for a long time, but now became noticeable as the child starts to grow and goes to the school. There is no pain, no redness, and the child reports mild blurring of vision in the left eye, especially when trying to read the board at the school. There is no history of trauma or previous ocular surgery. Birth and developmental history are remarkable. Now, what's your spot diagnosis? What's the management of this case? What's the potential complications? Describe the histopathology, and what's the most important investigations? So we'll discuss this case and elaborate the important points. Keeping in mind that this is a case, the spot diagnosis, this is a choriostoma or limbal dermoid, as you can see here, and perhaps also he has a lipodermoid. When you expose the upper lid, there might be a lipodermoid as well. But now we will concentrate our discussion on the limbal dermoid only. So as I said, the spot diagnosis, this is named as choriostoma or a limbal dermoid. Involving the corneal scleral limbus, involving the superficial cornea, corneal stroma, and sparing the anterior chamber. And what's the management of this case? Of course, the management usually conservative management. If the lesion is small and non-progressive and not visually significant, so only just conservative management. Surgical interventions is indicated when there is significant astigmatism affecting the refraction of the patient more than one diopter, or any affection that disturb the visual axis leading to amblyopia, because there is risk of amblyopia in these children, and also any cosmetic concern is another surgical indications. Now, the surgical approach after doing the necessary investigation that I will speak about them ranges from superficial lamellar keratectomy with just for superficial lesions, lamellar keratoplasty if it is deeper in the stroma, and most likely you can do even DALK procedure for this portion, sectorial DALK, and amniotic membrane transplantation for the reconstruction of the affected portion. The other question is that what are the potential complications if neglected? As I said, there might be refractive consequences leading to amblyopia to the patients, ocular surface persistent epithelial defect due to irregularity and movement of the lid will not be comfortable, and thinning sometimes of the cornea can endanger the risk of perforation and superadded bacterial infection. Now, the most important investigation in these cases is, as you can see here, is the anterior segment OCT and UBM, that is biomicroscopic ultrasound. This is very important to keep it in your mind before doing any surgical intervention, that you have to do anterior segment OCT to determine the extension within the cornea, at what level is it involving the Dismas membrane or not, and biomicroscopic ultrasound to determine the extension within the anterior chamber or deeper into the sclera. So these are the most important, because accordingly you decide your plan and your management. As you can see here, partial thickness sclerectomy along with the partial keratectomy is done, so that you can remove the whole sac completely without puncturing the sac, because it contains irritating materials. Then you will secure the wound with amniotic membrane, and after applying mitomycin and amniotic membrane to reconstruct the surface, and then use the glue, the fabric glue. This is the most common approach for these cases. Now, as far as the histopathology, the limbal dermoid is, as I said, choristoma, means that there is a benign congenital tumor composed of normal tissues in abnormal location. So choristoma, by definition, that you find abnormal tissues in normal tissues in abnormal location. There is normal tissues like hair follicles, you will find them, sebum, and but they are found in abnormal locations, usually with high keratin, which is with a stratified squamous epithelium. So this is the main component with the chronic inflammations. So this is the composition or the histopathological components. Now, as you can see here, after applying the mitomycin for a few minutes, so that eliminate the inflammation in this area. Now this area is ready for amniotic membrane application, and after doing this diamond burr to make the edge slopy, not sharp edge, the vertical edge is smoothened with this diamond burr, so that you can apply the amniotic membrane as inlay graft, as we have explained in the lecture of the amniotic membrane. This is the amniotic membrane. So you place it and secure it under the edge of the conjunctiva after applying the fibrin glue, and then the operation is finished, so that the healing will take place and the reconstruction of the surface will take place with the help of this amniotic membrane. Now he's injecting the glue below the amniotic membrane so that it will adhere into the surface, and this will help in the re-epithelialization and reconstruction of the ocular surface. Two types of the fibrin glue is using, the thin one and the thick one. You can see it is securing the edge like this. Now, one of the important perils that you should keep it in mind, and the examiner might ask you, and actually you need to examine your patient for any presence of any auricular skin tags, so that there is one syndrome named as golden hair syndrome, in which there is bilateral, usually limbal dermoids with auricular skin tags and cervicospinal abnormalities. So you should keep this syndrome in your mind. The examiner might interested and ask you about the syndrome. As you can see here, this is the hair originating from the cyst. This is the limbal dermoid, large one, and this is the anterior segment OCT to determine the extension of the cyst, that it is not involving the Dismas membrane, so that you can do bulk operation for this patient. And this is the skin tags. This is another case scenario for an important scenario, that is patient with Fox endothelial corneal dystrophy and subclinical corneal edema, and he has cataract as well, and he came for you complaining of gradual worsening and difficulty in reading, and he has history of Fox endothelial dystrophy. Visual acuity is 20/30 in the right eye, 20/40 in the left eye. Intraocular pressure normal in both eyes, and on a slant lamp examination, +1 to 2 theta is seen by specular microscopy, and mild nuclear sclerosis in the right eye, and minimum cortical cataract also in both eyes. And the management, the question now, how you are going to deal with this case. Now, the aim of this scenario is to discuss with the candidate what are the options available. First of all, to identify what's the main cause of blurring of vision of this patient. This is very important. You should ask yourself whether the disturbance of vision in this patient is due to the cataract itself or due to the corneal pathology itself, or both. Another thing is to discuss and decide whether to go for a single operation, that's you do cataract surgery first, and later on you plan for endothelial keratoplasty, or you go first for endothelial keratoplasty and you preserve and keep the patient for later phacoemulsifications, or you do a triple procedures like triple DMAC. So the aim of this case scenario is to discuss all these options and know the criteria for each one of these. This is summary of the patient's data, as you can see here. And from the patient's data and the picture, as you can see, the pachymetry is 546 in the right eye and 564, which is normal in both eyes, because we are dealing with subclinical edema. Subclinical edema, as we have discussed before, that we have three criteria to identify the subclinical edema based on the tomography: is the presence of irregular isopax of the cornea, and mild displacement of the thinnest point of the cornea, and finally posterior elevation map shows central depression towards the anterior chamber. Now when you see this patient for both right and left, there is loss of the corneal isopax, as you can see here in the pachymetry. There is sharp step from thinnest point to the thick point, much obvious in the right eye as compared to the left eye. Also there is mild displacement of the thinnest point, and also when you look closely to the elevation map, you will find negative sign is present in the elevation map. So this is indicate that there is there is central depression towards the anterior chamber. So all of this criteria is suggestive of subclinical corneal edema, and this indicates that this patient is at high risk for developing corneal decompensation, especially if superadded by unsuccessful phacoemulsification. Similarly here, this is the specular endothelial microscopy. You can see that the endothelial cell count is reasonable. However, as I said earlier, that we shouldn't depend on the cell density only, especially in the presence of confluent gutata that masks the counting of the endothelial cells. However, you can see that the hexagonality is very minimum in the right eye, only 17%. However, in the left eye is reasonable, and the coefficient of variation also is reasonable, less than 30% in both eyes, indicate the minimum polymorphism, but this mainly has polymorphism. So from this data, you can see that the right eye is much affected as far as the subclinical edema, as well as the specular microscopy. So if we plan to do the surgery, we will start with the right eye. Now in the next discussion, we will discuss how can we decide between a single operation or combined operations, and what are the precautions that we have to take care during the operation. The answer for this scenario is not as simple as you think. I have made this infographic diagram to guide you how to proceed with this case. That's a critical case. We are going more deeper, that we are dealing with a case of cataract, but also has Fox endothelial corneal dystrophy. This is one of the favorite subject by the examiner, so you should be able to deal with this case properly. Now, one of the important parameters is to determine what's known as the endothelial cell reserve, especially in the central part of the cornea. We have to, at least we have 2,200 cells per millimeter square in the central part of the cornea, as advised by American Academy, and this is not for normal person, but for a patient with Fox endothelial dystrophy, so that you can proceed with phacoemulsification. If you have this enough corneal endothelial reserve, you can go for phacoemulsification. If you don't have this enough reserve, so you have the option either to go for doing the endothelial keratoplasty first as a two-stage procedure, and later on you do the phaco, or you go for triple DMAC or DSAC, so that you do a combined procedure. So you start with this endothelial cell reserve. And if you decided to go for phacoemulsifications, now you have to go through a set of pre-operative counseling for the patients, and Also, you have to modify your intraoperative technique, and you pay special attention post-operatively so that you can guarantee and secure a safe procedure for this patient. You have to sit with your patient, discuss him the risk of doing phacoemulsification in your case, and that high chance in the future that you will need to do endothelial keratoplasty. And also you have to take the precautions during the intra-operative procedure so that you can use copious amount of dispersive and cohesive substances. As you can see here, the dispersive substance coating the endothelium, and the dispersive substance maintaining the space for the operation so that a minimum damage to the endothelium. There are certain parameters that you have to take care during your phaco procedures. We will speak about them in the next slide, but what I want to say that you have to go through a gentle phaco technique with low energy and high dispersive and viscoelastic so that you can guarantee a very safe surgery to the corneal endothelium. Also, you can plan for femtosecond laser assisted cataract surgery. This is one of the options. Post-operative care, you should follow your patient carefully for any evidence of significant corneal edema or subclinical corneal edema. And one of the important things that you have properly measure the intraocular lens power. As I will mention in the next slide, the high risk of hyperopic shift in these cases is very high due to the presence of corneal edema. So to avoid this refractive surprises after the cataract surgery, you should target for a minus 0.6 of myopia to these patients to counteract any refractive surprise of hyperopic shift. I will explain the mechanism of this hyperopic shift in the next slide. Now, why this hyperopic shift happens? As you can see here in a patient with Fox endothelial corneal dystrophy, as we have explained earlier, one of the features of subclinical corneal edema is that the posterior surface of the cornea will sink down to the anterior chamber, and this will increase the oplateness of the posterior surface, means it becomes more steeper. So when you do the keratometry, as you know, most of the biometry machines assumes a fixed ratio between the anterior surface and posterior surface of the cornea. So this shape of the cornea will disappear after doing the DMAC. So now the ratio will be returned to another figure. So if you assume this picture and during your biometry, most likely you will have a hyperopic shift for the IOL power calculation. That's why it is always advised to aim for a myopia of minus 0.6 to avoid any refractive surprises. Now, another important options or question arise, would you like to go for a single operations or a sequential operations? What are the pros and cons for each procedure? Now, if you go for combined or sequential operations. Now, the combined surgery, of course, as you can see that you do both the cataract and the DMAC at the same time. This is advantageous to the patient that he would go for a single operations, avoid the hazards of anesthesia and recurrent admission to the hospital and so on. However, the disadvantage of this approach, that is the combined approach, that is the risk of inaccurate IOL calculation, as I said, due to hyperopic shift, and also you are dealing with phaco in a small pupil patients, so that this may be more technically difficult for the surgeon. Now, if you choose to go for the sequential approach, now the question arises whether to go for DMAC first and then followed by cataract surgery, or the reverse, and what are the pros and cons for each one. Now, if you go for a DMAC first and then you will plan for cataract surgery, the advantage that you improve the predictability of your IOL power, because you will do the biometry after you solve the problem of the corneal edema. However, the disadvantage that you'll expose your graft to the hazard of cataract surgery and the ultrasound energy. Now, if you go for cataract surgery first, then you plan for DMAC. Now you will do the cataract surgery first, so the advantage that the DMAC will be avoided the risk of phacoemulsification later on, and you can do your phaco surgery comfortably, and you plan later on for the DMAC. However, in such cases, if you delay or postpone the DMAC operation, the disadvantage that the patient is high risk for endothelial decompensation and worsening his visual acuity, and he will not be happy until you do the DMAC surgery for him. So these are the different variable pros and cons for each approach. Now, there are certain important tips that you should keep it in your mind when you plan for phacoemulsification in these patients, that you have to do a very gentle phacoemulsification with very low parameters of ultrasound, and also low fluidics. That's to say low irrigation, and everything should be low, because the ejection current of the phacoemulsification will induce damage to the endothelium. Also, you have to modify your technique to assume the chopping technique or the disassembling of the nucleus. That's to avoid the ultrasound energy and avoid the old technique of the divide and conquer. And if you can do the soft chill technique, also is advised in these cases. All the flow parameters should be very low, and as I said, copious amount of viscoelastic should be used. And another important point for the IOL implantation, it is better advised to use a monofocal IOL rather than multifocal IOLs for refractive reasons, and also to use a single piece IOL rather than 3 pieces IOL. And this is also another important point, because the single piece acrylic hydrophobic lenses are meant to be placed in the bag, and all the haptics will be inside the bag. And as you know, during the DMAC procedure, the injection of air or gas tamponade to secure the graft may affect the lens. So if the lens is not properly implanted in the bag, this may create a problem. Unlike the 3 pieces IOL, which is meant to be implanted either in the sulcus or in the bag, and in such cases, if it is not properly placed in the bag, so with the use of this air gas tamponade, this might lead to displacement of the lens. So it is better advised to use a single piece lenses and acrylic lenses and monofocal rather than multifocal lenses. Another final point to show you here, that you can see that with the retroillumination of the operating microscope, a good examiner, you can notice the black dots which is present in the red reflex. This is due to the corneal gut data or the gutti of the cornea. And even if you don't, you miss this finding by slit lamp examination, and you find this picture, you should know that you are dealing with a patient with corneal gutti, and he has a risk for endothelial damage. So you should adjust all your parameters to avoid any further damage to the corneal endothelium. This is another case scenario for a patient who sustained a red eye with blurring of vision, watering, and diminution of vision following a community outbreaks, most commonly due to viral keratoconjunctivitis. Also, he has periauricular lymphadenopathy. The problem that this blurring of vision lasts with the patient for more than 6 weeks till now. Now, apart from the diagnosis, the questions are: what is the cause for this blurring vision from anatomical point as well as topographical point of view, and what's the management, and what's the inhibitors of the calcineurin pathway, and what's the relation with this case. As I said, that this case is a case of adenoviral keratoconjunctivitis, and this white infiltrate is subepithelial infiltrate. And this is the OCT picture, which is clearly shows the irregularities of the surface of the epithelium, and also the hyperreflective areas below the epithelium, that is subepithelial haziness or subepithelial fibrosis. Now, in the next discussion, we will discuss about the explanation for this blurring of vision, as well as what's the management for this case. Now, to open the discussion about this case, this is a case, as I said, this is subepithelial infiltrate due to adenoviral epidemic keratoconjunctivitis, which is a contiguous eye disease caused by multiple varieties or subtypes of adenovirus, namely 8 and 19, 37, 53. And the pathogenesis of this subepithelial infiltrate is an immune-mediated response, and it is not due to an active viral replication. So this is very important to be understood, that it is an immune-mediated response and not due to an active viral replication. Why we should understand this? Because when we speak about the management, based on this fact, we will proceed with the management, that there is no active viral replication, but it is an immune-mediated response. And this subepithelial infiltrate usually develop 1 to 2 weeks after the symptoms begins, and these opacities may lead to an irregular cornea and subepithelial opacities that decrease the visual acuity and decrease the quality of vision due to the high astigmatism. And as a result of this, the patient will complain of photophobia, glare, halos, and also drop of vision and the quality of the vision because of the high order apparitions. So, as you can see in this picture, the irregularities of the mirrors of the placido disc is due to irregularity of the surface of the cornea, and this will lead to decrease in the quality of the vision and high order aberrations. So the reason why this patient is complaining of blurring of vision, number one, because of the high order aberrations. Number two, irregularities of the surface of the epithelium will lead to high irregular astigmatism, and the patient will complain of blurring of the vision. So this is the explanation why the patient has poor vision. Now, as far as the management, as you know, the steroids is the mainstay of management of these cases, that it suppresses the inflammation. But as you know, that steroids for a long time, they carry the risk of elevated intraocular pressure and sometimes flare up of the problem after tapering of the steroids. Now, another alternative option is the tacrolimus. 1% eye drop. This is very important drug that's used in such cases, especially when there is contraindication for steroids. It's an immune modulator that suppresses the immune response and effective in resolving the surface irregularity and placido distortions, and also it has no effect on the elevation of the intraocular pressure. Another alternative is the use of cyclosporine A, which is also another immunomodulator. It has similar efficacy to the tacrolimus, but tacrolimus is more potent than cyclosporine A. We'll speak about these two as an inhibitor for the calcium-urine pathway. Now, recently they use a combination of povidone iodine drops along with the steroids, or in combination with tacrolimus. This is because the povidone eye drops will prevent the replication of the virus and accelerate the viral clearance from the cornea, and as a result, the risk of recurrence of this subepithelial infiltrate will be much reduced. So the best option for these patients is the combination of tacrolimus along with povidone iodine solution. Now, what are the difference between cyclosporine A and tacrolimus? Tacrolimus and cyclosporine A as a molecular weight, the cyclosporine high molecular weight, so it has moderate lipophilicity, and as a result, the penetration will be moderate, as compared to the tacrolimus, which has low molecular weight with very high lipophilicity, and so the penetration is very high. So tacrolimus is about 10 to 100 times more potent than cyclosporine A, and the only difference that the cyclosporine A is FDA approved. However, the tacrolimus is still not FDA approved and is used as an off-label treatment. So you should keep this fact in your mind, that tacrolimus is more potent and has better penetration for the ocular tissue and even more effective immune-driven corneal surface problems like vernal keratoconjunctivitis and subepithelial infiltrate, and it is used as off-label treatment. However, cyclosporine is less potent than tacrolimus, but it is FDA approved. Now, if the patient does not improve or get neglected for a long time, now you find in this picture that the surface irregularity is disappeared. There is no surface irregularities. However, there is persistent or chronic subepithelial fibrosis. Now, this can be demonstrated also by the use of what's known as corneal densitometry, so that you find this opacity, and also this patient will complain of poor vision. And this is the reason why when a patient uses steroids for a long time with on and off treatment and is neglected, so you find the surface irregularity disappear, but the opacities are persistent and became chronic. Now, in such cases, the best management for these patients is to use a customized topography-guided transepithelial PRK for the treatment of this persistent visually significant opacities secondary to the epidermal keratoconjunctivitis. Now, these patients, after this customized treatment, will notice that there is a significant improvement in the visual acuity and the quality of vision related to this correction of the surface irregularity, as well as the correction of the high order aberrations, and the surface of the cornea becomes more regularized, and all the topographic indices will be improved, and the patient will have an excellent outcome, especially if there is a combined with a refractive treatment that's patient having any associated myopia or hypermetropia. So this is in brief the management of this case of subepithelial infiltrates, starting from just medical treatment, ending up with surgical intervention that's customized topography guided laser correction. Now we come to the last portion of the same case scenario, that's the calcium-urine pathway. As you know, that cyclosporine A and tacrolimus both belong to the calcineurin inhibitors. And calcineurin pathway is mediated by T lymphocytes, and it is responsible for the ignition for the inflammatory process mediated by interleukins and cytokines. All are mediated by T lymphocytes. And by inhibiting this calcineurin pathway, we can modulate the immune response of the host and prevent the production of the subepithelial infiltrates. So both cyclosporine A and tacrolimus belong to the calcineurin inhibitors. And how they inhibit this calcineurin pathway? By two different mechanisms. The cyclosporine A by binding to the cyclophilin, a component of the calcineurin, and the tacrolimus by binding to the FK binding protein. Now, the clinical difference in the applications of cyclosporine A and tacrolimus: cyclosporine A primarily used in a dry eye or in graft versus host rejection and in mild allergic cases. However, tacrolimus mainly used in vernal keratoconjunctivitis and subepithelial infiltrate and any steroid-dependent inflammations. The onset of action of cyclosporine is slow, 4 to 6 weeks, as compared to the tacrolimus, which is more faster. And the effectiveness in cyclosporine A is moderate. However, as I said, that the potency of tacrolimus is much more potent as compared to the cyclosporine. And as far as the tolerability, often very mild stinging sensation with cyclosporine A. However, with the tacrolimus, more tolerable when compounded in aqueous form and placed in aqueous form. There is no much complaints of the patients. The effect of the both of them, they have no effect on the intraocular pressure, and the only thing, as I said, that the cyclosporine is FDA approved and present as an ointment is in the form of rhistiasis, and tacrolimus is used as an off-label ointment. So this is the difference as far as the clinical applications of both drugs. This is another case scenario of a 70 years old male presented 3 weeks after penetrating keratoplasty with due to pseudophakic bullous keratopathy. He reports persistent foreign body sensation, reduced visual acuity, and by examination a positive corneal staining is present near to the graft-host junction and with reduced tear film breakup time. No signs of rejections and corneal sensation is reduced. Now, you can understand from this scenario that this is a case of non-healing epithelial defect after penetrating keratoplasty, and most likely due to neurotrophic keratitis, because he mentioned that there is a decrease in the corneal sensation, and this is expected after penetrating keratoplasty. So you can see the list of questions here all are concentrated on the differential diagnosis, what's the immediate management, and what are, as far as medical as well as surgical management, and what are the recent advances in the management of neurotrophic keratitis, and finally what's the McKay classification. So the diagnosis is easy, but the discussion is very important here regarding this case. So you should be prepared for any question regarding neurotrophic keratitis, what are the causes and what are the differential diagnosis and how we manage such case. Now, before I start answering the case scenario, I just like to give a brief introduction to the innervation of the cornea. And as you know, the innervation comes from the trigeminal nerve through its ophthalmic division, which provides the nasociliary nerve and in turn provide the long ciliary nerve. And these will form the subbasal plexus that enter to the cornea radially around 70 plexus to form the subbasal plexus, and finally gives the final nerve ending to the cornea. And the cornea is one of the most rich in the nerve supply and very sensitive structure that is around 400 times more than the sensitivity of the skin. So this is just keep it in your mind for any subsequent discussion. So the diagnosis, as I said, both penetrating keratoplasty, persistent epithelial defect. He will ask you, or sometimes the examiner asks you, what's the meaning of persistent epithelial defect? When the defect stay more than 10 to 14 days after a traditional or routine treatment, this is named as persistent epithelial defect, which is seen in 15 to 20% of the cases after penetrating keratoplasty, especially in susceptible people like in diabetes mellitus or herpes simplex infections. Also, people with dry eye and limbal stem cell deficiency and ocular surface problem, they are at risk of this neurotrophic keratitis. And the main features, you will find disproportionate between the clinical signs and the symptoms. In advanced case, you will find significant clinical signs in the form of big ulcer, rolled edges, but you will find no pain. But initial stages, as we will explain in the McKay classification, you will find some element of pain in the cornea. And if you neglect these cases and you don't deal with them properly, you are at risk of superadded bacterial infection, stromal melting, perforation, and you will lose the eye. And if you have a corneal graft, you will have rejection of the cornea. Now, what's the McKay classification? You should be aware of this classification when you speak about neurotrophic keratitis. This is classified as stage 1, stage 2, stage 3, based on the severity. Stage 1, just you find punctate keratitis with the positive staining, as you can see here. And this stage is usually confusing with dry eye. So sometimes you will not be able to differentiate between the neurotrophic keratitis and the dry eye in stage 1 because still the corneal sensation is preserved in these cases, but you find just punctate staining. However, in stage 2 and 3, now the corneal sensation start to be reduced, and you will find the beginning of corneal ulcerations, and at the end stage you will find persistent defect with rolled edges. So this is the McKay classification, and in such cases the treatment ranges from just a supportive therapy in the form of a preservative free, and this is very, very important. You should start an aggressive lubricant treatment and should be preservative free because the preservative material itself, like the benzalkonium chloride, is toxic to the nerve ending. Warm compress punctal plugs because the coexistence of dryness will be there, and bandage contact lens and topical immunomodulators. However, this is to some extent is controversial because it depends on the underlying causative etiology for this neurotrophic keratitis. Generally, it is advised not to use steroids or non-steroidal anti-inflammatory in neurotrophic keratitis. And another important point is that each and every case of neurotrophic keratitis is usually associated with a dryness. However, not each and every case of a dry eye is associated with neurotrophic keratitis. This should be kept in your mind because, as you know, we will speak later about the trophic effect of the nerve ending. Nerve ending is responsible for the tear production in the eye. So any patient with neurotrophic keratitis, he will have some disturbance in the reflex tearing and the movement of the lids, so they will have element of dryness, but not necessarily each and every case of dryness they will have neurotrophic keratitis. Now, as far as the restorative therapy, it means that the therapy which is targeting to regenerate the nerve ending. And in the top of the list will comes the amniotic membrane, especially the prepared cases like Brocaria. And recently the use of genetic engineered amniotic membranes is used for such cases because they make the amniotic membrane enriched with some nerve growth factor that help in the regeneration of the nerve ending. So by genetic engineered amniotic membranes, they target the regeneration of the nerve ending in neurotrophic keratitis. Also the use of autologous serum, and recently also the use of umbilical cord serum. Umbilical cord serum also found to have a strong effect in the regeneration of the nerve ending. Now, the most famous drug available in the market is the recombinant nerve growth factor, Singramine, which is a recombinant nerve growth factor that helps in the regeneration of the nerve ending, and in turn it will restore the trophic function of these nerves to the corneal epithelium. And sometimes we need to do tarsorrhaphy, especially if there is associated lid pathology. And recently they use what's known as corneal neurotization. We will speak about this corneal neurotization. You should aware of this procedure because the examiner might ask you about this technique. So in general, the differential diagnosis ranges from infectious keratitis, which can be easily ruled out by the absence of infiltrate and discharge or pus, and exposure keratopathy by the presence of normal sensation of the cornea, and also you might find the presence of lag of thalamus. So this is more in favor of exposure keratitis. And graft versus host rejection or attack of rejection in the cornea if there is neurotrophic keratitis post keratoplasty. And as I said, if you don't deal with this case aggressively, you might end up by stromal melting, abscess formation, and then perforation, and the eye will be lost. Another important aspect that you should know, what I mentioned earlier, what's the corneal, what's the trophic effect of the corneal nerves? What we mean by the trophic effect? Now, the trophic effect, that the corneal nerves are not just for providing the sensation of the cornea, but they provide other important mediators that help in the proliferation, regeneration, and maintenance of the corneal epithelium. For example, growth factor release of the growth factors, namely the substance B, the nerve growth factors by name, and acetylcholines. All these mediators, they promote the proliferation, migration, and differentiation of the corneal epithelium. Also, the epithelial maintenance and healing. The nerve ending are very important to maintain the stimulation of the basal cells and stimulate the mitosis of the basal cells, and also promote the cell adhesions and help in the wound healing. So when there is denervation of the cornea, there will be disturbance in the mitotic activity of the basal cells and the cell-to-cell contact adhesions, and in turn this will affect the wound healing. Finally, the supportive effect for the epithelial barrier. Now, the nerve ending, especially the nerve-derived factors, upregulate the expression of tight junctions and the proteins, and maintain the corneal or the epithelial thickness, which resist for any external insult. So healthy and intact corneal nerves is very important to maintain the healthy of the corneal epithelium. And also in the tear secretion regulation, as you know that the corneal nerves trigger the reflex lacrimal gland secretion via the trigeminal nerve, and also the nerve ending modulate the immune response. So some mediators and nerve peptides will have local immune response that control the inflammation and support the anti-infective defense effect of these mediators. Finally, you should be aware of what's meant by esthesiometry. That's the assessment of the corneal sensation. This should be kept in your mind, because the examiner will ask you how we assess the sensation of the cornea by the use of esthesiometry. And we classify or grade the cornea, central cornea and peripheral cornea. And the peripheral cornea is divided into 4 zones. Accordingly, you will mention whether there is absent sensation, reduced sensation, normal sensation, or sometimes increased sensation. Sometimes in some diseases, there will be increased sensation of the cornea. There will be exaggerated response to any stimulus to the cornea. And this is named as corneal neuropathic response, or neuropathic response. It is not neurotrophic keratitis, but it is neuropathic response. So you should be aware of this technique, that's corneal esthesiometry, using the swab cotton, piece of cotton, or you can use any fine tissue that you can stimulate the cornea. So this is in general the important points that you should keep in your mind for any discussion regarding neurotrophic keratitis. Now, in the next slide, I will speak about the corneal neurotization, because the examiner might ask you about this. This diagram shows the innervation of the cornea, starting from the limbal nerve plexus after emerging from the long ciliary nerve branch from the trigeminal nerve. Now, this limbal plexus, as I said, they will penetrate radially to the cornea, around 70 plexus. There will be penetrating in a radial fashion to the cornea. Then this limbal plexus will pass through the stroma to form the stromal plexus. And then this stromal plexus will provide the subbasal plexus below the Bowman's membrane. And then from the subbasal plexus, they form the subepithelial plexus, and finally the intraepithelial terminals and nerve ending. So as I said, that the cornea is rich in the nerve supply, and it is more sensitive than the skin by around 400 times. Another important fact that should be understood, the close interrelationship between the nerve ending and the nerve supply and the epithelial cells itself. Now, the innervation of the cornea is very important for the epithelial survival and epithelial homeostasis, because the nerve ending, as I said, release important neuropeptides like the substance P and other substances that's important for the maintenance of the epithelial homeostasis and maintain the epithelial proliferation and adhesion and wound healing. But at the same time, the epithelial cells itself produce certain neuropeptides that are responsible for the survival and the health of the nerve ending. So there is a close relationship between the health of the nerve ending as well as the epithelial cells. So each one of them support each other. This is very important. When there is damage to the epithelium, there will be subsequent damage to the nerve ending. And when there is damage to the nerve ending, this will lead to damage to the corneal epithelium. Now, another important question that you might face from the examiner, which is the mechanism of topical anesthetic abuse in neurotrophic keratitis. As you know, one of the incriminated causes of neurotrophic keratitis is the topical use or abuse of topical anesthetics unsupervised by doctors. So this will lead to a chance of neurotrophic keratitis. You know that the pharmacodynamic of the topical anesthetics, like the propacaine, tetracaine, oxybuprocaine, all of them, they block the voltage gated sodium channels that inhibit the nerve impulsion and transmission, and this will lead to prevention of the action potential and the conduction through the nerve. Of course, this is a reversible effect. However, the chronic judicious use of these topical anesthetics, this will lead to direct neurotoxicity to the nerve ending, and this direct neurotoxicity will prevent the regeneration of the nerve ending, and there will be axonal degeneration, and as a result, there will be no release of the neuropeptides responsible for maintenance of the health of the corneal epithelium. Also, there is a direct cytotoxicity of these materials to the epithelium itself, and as I said, damage to the epithelium will in turn lead to damage to the nerve ending. And reduced neuropeptide secretions will impair regeneration of the nerves and will lead to increase the risk of corneal ulcerations. And as you know, when there is topical anesthesia to the eye, this will reduce the blinking reflex and tear production and lead to subsequent dryness. So this is the mechanism of action of topical anesthetic, that they block the sodium gated channels at the nerve ending, prevention of action potential. When chronic use, there will be permanent damage to the nerve ending and axonal degenerations, and will predispose to the neurotrophic keratitis. So chronic topical anesthetic abuse destroy the corneal sensory nerves and depriving the cornea from vital trophic factors that directly damage the epithelium, creating a perfect setting for development of neurotrophic keratitis. Now we will speak about the important subject, that's the corneal neurotization technique. Any discussion about the neurotrophic keratitis, you should be ready to speak about the corneal neurotization technique, because the subject is very common in the western part, and most likely the examiner, he will ask you about this recent advances in the management of neurotrophic keratitis. Corneal neurotization represent a recent advance in the management of neurotrophic keratitis, and offering restoration for the corneal sensation and also the ocular surface in otherwise untreatable diseases. That's why it is indicated for advanced cases between stage 2 and 3 McKay classification, and after you have depleted all the medical available treatment, so that the only solution for you is to use this corneal neurotization. Now, the technique is simple, that it can be a direct corneal neurotization or in indirect way. The direct way, it means that you use an ipsilateral or contralateral supraorbital and supratrochlear nerve, either ipsilaterally like this or contralaterally. So is dissected, the nerve is dissected identified and passed through a bridge of the nose, and passes through the supra or upper crease of the lid, and passes in the through the fornix to the subconjunctival space and subtenon space, and then secured around the limbus, so that this allow for the vesicles of the nerve freed from the epineurium, and the axons will grow and innervate the target tissue. This is the direct way in which you use the patient's own nerves. However, the indirect way, that you use the sural nerve either from the patient himself or as an allograft from the shelf that's available in the bank. So that the most important is here is the nerve is coapted after we identify the supraorbital nerve, and then the sural nerve is coopted with this nerve, and the same thing, it passes through the nasal bridge, below the nasal bridge, and passes to the contralateral eye, so it innervates this. The reason why I prefer to use the contralateral eye, to make sure that there is a totally healthy innervation for this part, because if there is damage to the trigeminal nerve, so this supraorbital and supratrochlear might be affected. And this picture also shows how the nerve, once it is reaching to the cornea, how it is secured in the subconjunctival space and also in the lamellae of the cornea. So this allows for the growth of the axons of the nerve and innervate the hypoanesthetized or anesthetized cornea. So this is just the brief words about the procedure and the technique. The examiner will be happy if you mention about this technique, and you just need to know the difference between direct and indirect neurotization. This is another interesting case scenario for a 60 years old woman planned for cataract surgery with the toric IOL implantation, but in the history she reported an intermittent attacks of blurring of vision and sometimes discomfort. On examination, some mild map dots fingerprint changes has been seen in the cornea, and topography shows irregular astigmatism. So this is a case of patient who's planned for cataract surgery with toric IOL implantation, but accidentally on examination they discovered that she has a fingerprint or map dot or Cogan's epithelial dystrophy. So now the next discussion will be regarding how can we deal with this case, especially in the presence of cataract, and what would be our plan for these patients. So the examiner might ask you what potential problem could arise if you proceed with biometry. Now your answer should be like this, that due to the presence of the epithelial basement membrane dystrophy, like this Cogan-Smithman fingerprint corneal dystrophy, so this will result in significant irregularities of the surface of the cornea, and this will lead to an irregular astigmatism and sometimes confound the result of the biometry. So the patient biometry will not be reliable in such cases. So your priority in these cases is to deal with the epithelial dystrophy first by doing certain surgical interventions, and after regularization of the surface of the cornea, you can plan for cataract surgery. Now, the examiner asks you again, or can ask you, how would you confirm the diagnosis of epithelial irregularity objectively? So, as you know, that the answer of this question objectively means that you utilizing an investigation. The most popular one is the use of anterior segment OCT based epithelial mapping, and by determining what's known as the total wavefront epithelial wavefront. Now, by this wavefront determination, we can confirm objectively the irregularities of the surface of the epithelium. And if the total epithelial wavefront error that is measured by the RMS, that's the root mean square, which is more than 1.04, this is diagnostic of significant irregularities, and hence it is related to the epithelial basement membrane dystrophy. So this is very important, and we have mentioned this in another slide when we spoke about the recurrent corneal erosion. So these patients might present with irregular astigmatism or with recurrent corneal erosions. So this is a new novel technique that you, based on the total wavefront error of the epithelium, based on the anterior segment OCT, or recently by the use of the pentacam corneal OCT that we will speak about it, you can determine how much the amount of the root mean square. If it is exceeding 104 microns, this is indicate epithelial basement membrane dystrophy. So the picture, as you can see here, the diagnosis is very easy, but the discussion is very important in this regard. Now, the another important question is, this patient is candidate for toric IOL implantation. As I have said, that this patient, the priority is to regularize the surface of the cornea first. Then we do the calculation for subsequent cataract surgery. But the question, are you going to implant a plain IOL, or you are going to use a premium IOL like a toric IOL? Now, this next discussion will be regarding this subject. So as I said, that you are going to confirm the diagnosis by doing anterior segment OCT, or recently the new technology which is known as the Pentacam corneal OCT, which provide optical sectioning of the cornea. Now this is a very high resolution corneal OCT, so that you can clearly see the irregularities of the epithelium and the Bowman's membrane, and also the irregularities of the surface of the epithelium. So this is, by this way we can confirm the diagnosis, apart from the, as I told, determination of the total wavefront error of the surface epithelium. This is one way how to we confirm the diagnosis. Now when you look to the topography for this patient, you will find significant irregularities with areas above and areas below. This is suggestive of significant irregularities of the whole surface of the cornea. And when you apply the principle of the total epithelial wavefront, you will find significant oblique trifoil and horizontal trifoils, and sometimes even quadrifoil. This wavefront profile of this patient indicate significant high order aberrations, and this contribute to the blurring of the vision of the patients, and this also contribute to the inability to perform accurate biometry for subsequent cataract surgery. So in such cases, the priority is to regularize the surface of the cornea first, then you plan for subsequent IOL implantation or cataract surgery. Of course, with this picture, toric IOLs is absolutely contraindicated in these patients because of the presence of high order aberrations, and you have no regular acts that you apply the toric IOLs unless you regularize the surface, and after that you perform another topography. Accordingly, you can decide whether you are going to plan for toric IOL if there is significant astigmatism, or you plan for plain IOL implantation. In completion to the management of this case, whether we are going to implant toric IOL or not, as I said, that this patient is not good candidate for toric IOL or any premium IOL unless you regularize the surface utilizing whatever tools that you have, as I said, after confirming the diagnosis using the high resolution anterior segment OCT, or the new innovations of the combined Chamflock and anterior segment technology named as Pentacam corneal OCT, which will provide a high resolution image named as optical sectioning of the cornea. And after regularization of the surface of the cornea, confirm it by another parametry or topography, so that you find reduction in the high order aberrations and you can determine the axis of the astigmatism. At that time, you can decide and go for toric IOL implantations. Now, how you will regularize or treat this patient? Of course, after medical lubricants, you can go for epithelial debridement using the diamond polishing, and also you can do anterior stromal puncturing, and this is especially if there is recurrent corneal erosions but will not regularize the surface. This is for the treating recurrent corneal erosions if coexistent with this case. And finally, the use of customized phototherapeutic keratectomy, that is PTK. This is very important to remove the abnormal irregular epithelium with abnormal Bowman's membrane, so that the new formed epithelial cells will be regular and without undulation or high astigmatism. So like this picture now, after regularization of the surface of the cornea, and you can determine the axis of astigmatism, in this situation you can go for toric IOL implantation. Otherwise, better to go for plain IOL implantation rather than premium IOL implantation. This is another case scenario for a 36-year-old female patient presented 2 months after history of LASIK procedure for both eyes. Now presented with an acute episode of acute pain and watering and blurring of vision in both eyes, especially when wakened in the morning. Now, when the examination reveals only just microcystis in the epithelium and especially near the hinge of the LASIK flap in both eyes. Now, as you can see the picture here, this is a positive staining for the cornea, suggestive of epithelial defect, and this is the appearance of the eye before the fluorescein staining. Now, the first question is, what's the most likely cause for this recurrent corneal erosion? And how would you differentiate this heterogeneous post-LASIK erosions from recurrent corneal erosion due to epithelial basement membrane defect? And how would you confirm the diagnosis? and what's the your management plan, and finally outline briefly the how BTK will alter the corneal epithelium in epithelial basement membrane defect and its effect on the wavefront error. Now, from the first glance, you think that this is a very simple case, but as far as the diagnosis is simple, but the discussion behind the diagnosis is not as simple as you think. And this is the how we differentiate between a clever and good student, knowledge-wise, and those who are not prepared well for this such subject. So we will start answering this slide and scenario in a systematic way so that you know how to tackle this case. And by the way, this is one of the famous and common lovely scenarios liked by most of the examiners in the FRCS. That's the recurrent corneal erosion syndrome. Now we will start with the answer of the first question, which is what's the most likely cause of this recurrent corneal erosion? Actually, when you revise the history, that you will find that there are certain points in favor of heterogeneous post-traumatic recurrent corneal erosions, and also another points in favor of epithelial basement membrane dystrophy with associated recurrent corneal erosion. Now, the presence of the recurrent corneal erosions near to the hinge of the LASIK flap and appearing immediately or after a few weeks after LASIK procedure in both eyes, all of these are in favor of post-traumatic recurrent corneal erosions. However, as it's mentioned that in the examination they found microcystis in the epithelium, this is in favor of epithelial basement membrane dystrophy or Cogan's dystrophy. Now, detailed history important here. If the patient say that there is similar attacks before the LASIK procedure, so this is might be in favor of epithelial basement membrane dystrophy. However, if he deny the presence of such attack before and only appearing after the LASIK, so this is more in favor of heterogeneous recurrent corneal erosions. Now, another important point is that we should differentiate between recurrent corneal erosions and persistent epithelial defects. Now, recurrent corneal erosions, this is a acute problem that happens immediately, especially on waking in the morning. Usually there is normal cornea, healthy cornea, and the healing edge is normal. However, in the persistent epithelial defect, this is a chronic indolent problem preceded by chronic insidious pathology of the cornea, like neurotrophic keratitis. Usually you'll find the edges are rolled up, and patient has less pain as compared to the recurrent corneal erosions. And in long-standing cases, you will find the ulcer with positive staining and thinning of the cornea, and sometimes infection, super added by infection. Now, why we should differentiate between this based on the history? Because the management will completely differ when you are dealing with persistent epithelial defect and when you are dealing with recurrent corneal erosion. So this should be kept in mind, that you don't be confused between the diagnosis of recurrent corneal erosions and persistent epithelial defect. Now, another point, how we clinically we can differentiate between the heterogeneous one, recurrent corneal erosion, and the one due to epithelial basement membrane dystrophy. And here to answer this, we should refer to the electron microscopy anatomy, as I mentioned in my lecture regarding the corneal anatomy. Now, when you look to the anatomy of the basement membrane after bypassing the epithelium, now the basement membrane by electron microscopy is divided into three layers: the lamina lucida, the lamina densa, and the reticular lamina. Now, the lamina lucida is the one here which is attaching or anchoring the epithelium to the basement membrane based on the hemidesmosomes and anchoring fibrils here. This is the location of the lamina lucida. And the reticular lamina, which anchoring fibrils, anchoring the basement membrane to the Bowman's layer. Now, for traumatic heterogeneous types of recurrent corneal erosions, the problem is here, is the anchoring fibrils here. So the basement membrane is healthy, and the problem is here. The separation happens at this level. However, in the presence of epithelial basement membrane dystrophy, there will be abnormal production of this anchoring fibrils and the hemidesmosomes, so that the separation will be at this level. This is from histological point of view. So when the examiner asks you pathologically or histologically how we differentiate between the recurrent corneal erosions due to heterogeneous cause or due to epithelial basement membrane dystrophy, your answer should be like this. So this is a brief summary of what we have said, that the difference between heterogeneous one and epithelial basement membrane recurrent corneal erosion, the history is very important here. The location also important, because in epithelial basement membrane dystrophy you will find the whole cornea is involved, mainly in the central part and the inferior part. However, in LASIK, nearly close to the edge of the hinge. Now the symptom, as I said, both of them will appear after appears after the LASIK procedure. This one might be preceded by the LASIK procedures. The slit gland examination, presence of microcystis in the epithelium. This is in favor of the epithelial basement membrane dystrophy. And the most important novel technique for diagnosing the epithelial basement membrane dystrophy is the use of OCT epithelial mapping, namely using the wavefront error. By studying the wavefront error from the epithelium, we can differentiate between both of them. I will explain in detail in the next slide how we utilize the wavefront error of the epithelium in differentiating between epithelial basement membrane dystrophy and heterogeneous one. Now we come to the third question, and we will answer it. That's how we would confirm the diagnosis, including the novel technique if available. As I said before, that the confirmation of the diagnosis of epithelial basement membrane dystrophy is done by the clinical examination, and you find the presence of microcystis in the epithelium. However, sometimes it is not as easy as you can expect, so that you will need to do anterior segment OCT, and mainly you do wavefront measurement for the epithelial mapping, and determine the total wavefront error related to the epithelium. Now, in the presence of heterogeneous recurrent corneal erosions, usually there will be focal irregularities in the flap. So the irregularity in the wavefront from the epithelium is localized. However, in epithelial basement membrane dystrophy, you will find generalized irregularities, and you will find high order aberrations, and the root mean square will exceed more than 1.04. This is suggestive of epithelial basement membrane dystrophy. However, in both LASIK cases, you will find localized defect, and you'll find it mainly near to the hinge, and there will be no significant high order aberrations. Now, to understand this, whenever there is a basement membrane defect in the cornea, due to epithelial basement membrane dystrophy, the corneal epithelium will be irregular, and this irregularity will be generalized over the whole cornea. So when we take the wavefront operations, we'll find generalized wavefront error more than 1.04. However, in the presence of heterogeneous recurrent corneal erosion, this will not be the case, and the problem just will be localized near to the hinge of the flap. Now, the answer for the other question, what would be the management? Of course, we will start with the conservative measures for both of the conditions, using the lubricants and eye drops and ointments. We use hypertonic drops like hypertonic saline, Mura 128, and we can use bandage contact lens as a temporary measures to promote the epithelialization, and sometimes short course of steroids if there is significant inflammations. Some people claim that the use of oral doxycycline will help in the epithelialization and also the adhesion of this epithelium, and the use of autologous serum also in reluctant cases. Surgical management in the form of debridement of this epithelium by a diamond burr. A diamond burr polisher that will be very useful to eliminate the abnormal epithelium and abnormal basement membrane, and this will help to regenerate normal epithelium and normal basement membrane. But this should be done with caution in patients with LASIK, especially near to the edge of the flap. Another thing is the use of anterior stromal puncture. This is also done, especially in the peripheral locations. Never do it adjacent to the hinge of the flap. This also will create low-grade inflammation and help to adhere the epithelium to the underlying basement membrane. Finally, phototherapeutic keratectomy, that's BTK, is persistent and recurrent cases and not resolving cases. Usually this is a very effective way for both of the cases, either recurrent due to LASIK or due to epithelial basement membrane dystrophy. So this is the most of the applications of this or the management, especially of course we shouldn't forget the use of amniotic membrane sometimes in reluctant and persistent cases. Also, amniotic membrane can be used in such cases. Now we come to the last question, which is what's the role of this BTK in healing of the corneal epithelial, either in epithelial basement membrane dystrophy or in post-LASIK recurrent corneal erosions? That BTK will ablate the irregular epithelium and the irregular abnormal basement membrane, and this will result in a smoothening of the corneal epithelium. As a result, there will be significant improvement of the vision of the patient because of the removal of the wavefront errors, and also improve the structural and functional outcomes of the normal emerging epithelium and basement membrane. So this is one of the important measures that improve structurally and functionally the corneal architecture. And recent studies, as I said, that demonstrate that this total epithelial wavefront error quantified by the RMS, that's the root mean square, measured by the spectral domain OCT anterior segment parametry, is very sensitive and specific biomarker for diagnosing of epithelial basement membrane dystrophy. And a cutoff value of more than 104 is diagnostic for epithelial basement membrane dystrophy. This is very, very important, and each one of you should memorize and mention this to the examiner, so that you will show up your capability for following up recent advances in this regard. Another thing, that the irregular epithelial basement membrane dystrophy is responsible for the degradation of the image, and also can lead to abnormality in the power of the IOL calculation. And this is very important point, because irregularity of the surface epithelium will lead to abnormality in the K reading. And as you know that the K reading, most of the biometry techniques, either optical or by ultrasound, dependent on the K reading. So whenever you have unreliable K reading, so your power calculation will be unreliable. So if the examiner asks you if you have a patient with epithelial basement membrane dystrophy and you are planning for cataract surgery, what will be your priorities for the management? Your answer should be like this, that you should manage the epithelial basement membrane dystrophy first by doing BTK, and after the condition subside and the surface regularity improved, and this is confirmed by the wavefront error below 1.04 micrometer. At that time, you can do K reading and do biometry, and then cataract surgery for your patients. This is another interesting case scenario in which the examiner wants to assess your knowledge regarding the management of herpes simplex in the presence of keratoplasty. So a 45 years old male with a history of recurrent herpes simplex keratitis who underwent penetrating keratoplasty in the left eye 18 months ago for herpetic stromal scarring. Now he presented now with photophobia, tearing, decreased visual acuity, and on a slit lamp there is a classical appearance of dendritic ulcers with terminal bulbs in the graft surface itself. So the diagnosis is straightforward. It is herpes simplex epithelial keratitis in corneal graft. Now the questions: what's the most likely diagnosis, and what's the appropriate management, and how you can deal with the complications? So the aim of this scenario is to assess your ability to utilize your knowledge regarding herpes simplex keratitis, as well as in the presence of keratoplasty. So in this case scenario, the answer should be like this. I simplify this by this infographic, that the management start like this. Immediately after you confirm the diagnosis of herpes simplex keratitis, immediately start with the therapeutic dose of antiviral in the form of topical antiviral, as well as oral antiviral drops, oral antiviral medications, 400 milligram for 5 days, or valproxyclovar 1 gram for 3 times a day for 7 to 10 days. This is the therapeutic dose of oral antiviral. So you have to use the combination of both. And at the same time, you should immediately stop the use of topical steroids, because in the presence of epithelial defect, this will worsen the scenario. So you follow your patient closely and look for the signs of complete epithelialization. If there is complete epithelialization, you can go ahead and continue with the prophylactic dose of antiviral. The prophylactic dose is less. Use the same topical medications, but the mainstay is oral acyclovir, and this time it will be just twice a day for at least 12 months. This is the prophylactic dose. So you should differentiate between the therapeutic dose as well as the prophylactic dose. So in the presence of epithelial healing, you start with the prophylactic dose. You can continue for this for 12 months, and also you can regain and resume the use of topical steroids if there is coexistence inflammations, and also as a prophylaxis from attack of rejection for your graft. Now, the scenario will be worse if there is no healing signs, there is no healing of the epithelium, in spite of your immediate therapeutic dose of oral acyclovir. In this scenario, you should expect the coexistence of neurotrophic keratitis along the herpetic keratitis. So you should use the another means for promoting the healing of this epithelium by the use of amniotic membrane graft, or the use of the topical nerve growth factor syngramine, and also you can use autologous serum along with the oral antiviral till the healing becomes okay. At that time you can start the prophylactic dose of antiviral and you start topical steroids. So I summarize the management of this scenario in which you find the case of corneal graft with dendritic ulcer. This is another case scenario of a 19-year-old male patient presented with sudden pale redness and significant loss of vision in the right eye. He's a known case of keratoconus using a rigid gas permeable contact lens. On a slit lamp examination, diffuse stromal haze with a characteristic oil droplet appearance, as you can see here. Nearly the whole cornea is opaque and hazy. And on OCT examination, there is increased hyperreflective signals from the cornea with increased corneal thickness, as you can see here. Also in this appearance with characteristic keratoconus. Also, there is vacant black spots within the stroma of the cornea, indicative this is a vacuoles and present inside the cornea. And you can see also here there's discontinuity of the dismus membrane. So this is most likely the cleft due to the dehiscence in the dismus membrane. You can see here also some sort of epithelial edema and also like a poly due to microcystis and huge poly present within the epithelium. So this is a case of acute corneal hydrops with significant stromal edema as well as epithelial edema, as you can see here by slit lamp. So as you can see, the diagnosis is not difficult for you as a postgraduate students. Now, the most important about this discussion is the questions behind the diagnosis. It is not always that the diagnosis is difficult, but what's important and bother the examiner is the discussion beyond the diagnosis. So what's the most likely diagnosis is acute corneal hydrops due to keratoconus, advanced keratoconus. What's the pathophysiology behind this condition? What's the expected visual outcomes? And what's the difference between, this is very important question, what's the difference between corneal edema in Fox endothelial corneal dystrophy and acute congestive glaucoma, and of course with acute corneal hydrops? This is very important question. So in the next discussion, we'll concentrate to answer all these questions. So the diagnosis is straightforward. As I said, this is acute corneal hydrops due to spontaneous rupture of the dismus membrane in advanced keratoconus, and the underlying pathology due to progressive thinning of the cornea with advancement of the keratoconus. There will be a risk of sudden rupture of the dismus membrane, and this will be presented with an acute influx of the aqueous into the stroma with the sudden stretch of the collagen fibers within the stroma, and this is the source of the pain and give rise to acute severe pain with congestion to the patients. And the visual outcomes expected that after some time this defect in the dismus membrane will heal, and there will be absorption of the water that's getting the stroma, and there will be fibrosis replaced by fibrosis, and the acute symptoms will subside, and even sometimes in some cases the vision improve after the acute attack of acute hydrops, because this fibrosis in the cornea will induce some sort of a flattening. As you know, in keratoconus there will be severe steepening of the cornea, and due to this fibrosis there will be some flattening of the cornea, and the patient will notice some improvement in his vision. But usually these cases is indication of advanced keratoconus and necessitate the need for surgical intervention in the form of penetrating keratoplasty. Like these cases, We cannot do DALC operation in these patients because there is defect in the distal membrane, and usually there is advanced thinning of the cornea. So the ideal management for these cases, after you manage the acute stage with topical drops, hypertonic salines, and cycloplegic drugs, sometimes we need to use steroids, provided that there is no evidence of coexisting uveitis, and monitor the intraocular pressure. After that, we should go and plan for penetrating keratoplasty for these patients. Like in this case, after the acute stage subsided, we go for penetrating keratoplasty. Usually the prognosis is good in these cases. Now, you should keep in your mind that not only keratoconus can cause acute eye drops, there are other rare diseases, but also they can cause acute eye drops beside keratoconus, like the pellucid marginal degeneration, keratoglobus, and sometimes trauma with rupture of the distal membrane can lead to acute eye drops. Rarely some infections with affection of the endothelium and the distal membrane. So these are rare causes of acute corneal eye drops. Now, another important question is that you might be asked by the examiner how you differentiate, or what's the underlying pathogenesis of the corneal edema in acute corneal eye drops and Fox endothelial corneal dystrophy and acute congestive glaucoma. All of them, they will lead to corneal edema, but the pathophysiology behind each one is completely different. For example, in acute congestive glaucoma, it is an acute problem. Also, acute eye drops is acute problem. Our Fox endothelial corneal dystrophy is a chronic progressive problem. And the main reason in corneal eye drops is due to defect in the distal membrane, in Fox endothelial dystrophy due to defect in the endothelial function, usually congenital problem, and acute congestive glaucoma is due to disturbance in the balance between the hydrostatic pressure inside the eye and the osmotic pressure inside the stroma, because sudden elevation of the intraocular pressure inside the eye will force the intercellular and the transcellular diffusion of aqueous to the stroma and surpass the capability of the sodium-potassium pump present into the endothelium to keep the corneal detrussion. So in the acute congestive glaucoma, usually due to elevation of the hydrostatic pressure. Although there is normal functioning endothelium, but the elevation in the pressure overcome the capability of the corneal endothelial pump mechanism to keep the stroma dry. This is the main pathophysiology for each one of them. As I said, corneal eye drops usually unilateral. Fox endothelial start usually bilateral, start in one eye, and also the other eye will be affected. Also, glaucoma is usually unilateral, and usually in the acute eye drops, localized defect due to rupture of the distal membrane. Fox endothelial dystrophy commonly involving the central part and sparing the peripheral part of the cornea. In glaucoma, it is usually diffuse corneal edema in glaucoma. Also, the other associated signs in acute eye drops, there will be pain and photophobia, sudden worsening of the vision. Usually, patient give history of keratoconus since long time. In the Fox endothelial dystrophy, it is slowly progressive, and you can find gutta present on a slit lamp examination, and patients will provide a history of slowly progressive drop in his vision. And in acute congestive glaucoma, you will find mid-dilated pupil not responding to the light, halos preceded by halos of right, and shallow anterior chamber. So this is the coexisting finding with a slit lamp. But the main histopathology, as I said, in the acute eye drops is rupture of the distal membrane and creation of sudden influx of water inside the stroma and creation of clefts inside the stroma. However, in Fox endothelial dystrophy, usually the distal membrane is thick. This is very important. In Fox endothelial dystrophy, because of congenital abnormality in the functioning of the endothelial cells, usually there is associated thickening of the distal membrane with gutta formation, which is nothing just an wart-like accumulations and extensions from the distal membrane that present in that area. So you find the distal membrane is thick. Now, in acute congestive glaucoma, usually the endothelium is normal. Just you might find swelling of the corneal endothelium due to the sudden rise in the intraocular pressure, and usually the patient will have both stromal edema as well as epithelial edema because the tension is sky high, so that the aqueous will bypass even the stroma and reach to the corneal epithelium and creating of pulli sometimes and microcysts. In acute hydrops, within weeks the condition and will improve and end up by healing of this defect in the dismal membrane, and the patient will improve. In Fox endothelial dystrophy, this is a slowly progressive chronic problem that requires at the end endothelial keratoplasty or penetrating keratoplasty. In acute congestive glaucoma, if you pick up the case early and you start your medication, usually the condition will be controlled within a few days. And at the end, you need further assessment to decide whether to just keep your patient on topical medications or use YAG laser iridotomy, or you go for filtration operations. So the prognosis is usually good for the glaucoma as well as for the acute corneal hydrops, and also for Fox endothelial dystrophy, provided you do the future management that's needed for each of these cases. So this is one of the important questions that you should know. The difference in the pathogenesis and the edema between these three categories. And of course, when we say, for example, Fox endothelial dystrophy, we give this as an example of endothelial dysfunction. So we can apply the same principles for posterior polymorphous corneal dystrophy, or for cases with endotheliitis, for example, or people with congenital hereditary corneal dystrophy. So any example of corneal dystrophy will give the same scenario as Fox endothelial corneal dystrophy. Another interesting case scenario for a 24-year-old man presented with a history of corneal scarring from healed herpes simplex keratitis. His best corrected visual acuity is 636 in the right eye, and slit lamp shows dense mid-stromal opacity with no endothelial involvement. Corneal thickness and endothelial counts are normal. So this is the data, and he asks you what's the ideal surgical procedure for this patient, and what's the advantage over other techniques, and what are the intraoperative signs suggestive of successful big bubble formation. Now, from the case scenario, as long as the endothelium is intact and the corneal thickness is normal, so the opacity mainly in the mid-stroma, so this is good indication for DALK. Provided, as I said, that you rule out involvement of the endothelium or increase in the pachymetry of the cornea. From the data he's given, so he's a suitable case for DALK procedure, which can be confirmed by high resolution OCT picture for the cornea using the pentacam anterior corneal OCT or anterior segment OCT. So this is ideal case for DALK procedure. Now, for those who don't differentiate between the full penetrating keratoplasty and the DALK, as you can see in the DALK, we take the cornea and the most of the stroma up to the posterior 1/3 of the stroma, and beyond that, nearly 90% of the thickness of the stroma is removed. So we preserve the dismal membrane and we preserve the endothelium of the patients. The advantage that as we preserve the patient's own endothelium, so the risk of rejection is less and the success rate will be more. As I said, that provided only the haziness or the opacity in the mid-stroma only, and it provides a good faster recovery and good structural integrity. Now, the intraoperative signs of big bubble formation, a clear cleavage between the deep stroma and dismal membrane. So this is indicate that there is a good separation between the deep layers of the stroma and the dismal membrane. Sometimes the cleavage will happen at the level of the duous layer. So this is also recognized in a cases of DALK procedure. The outcomes, as I said, is good, and the patients need, now in the management of this case, you have to take the precautions of the use of steroids with a prior history of herpes simplex keratitis. So in these patients, we should keep him on a prophylactic dose of the antiviral treatment, that is 400 milligram acyclovir twice a day, at least for 6 months to 12 months. And the patient should receive a balanced dose of steroids to avoid the inflammations and the attack of rejection under the antiviral cover, and to avoid the reactivation of the virus itself. and a patient should be followed carefully and on immunosuppression, and gradually taper the immunosuppressive drugs to a minimum dose. This is the precaution that you have to take care while dealing with such case with a prior history of herpes keratitis. This is another case scenario of a 55 years old male patient presented with history of 3 weeks of redness, watering, and progressive visual loss in the left eye. There is no any history of a previous illness or trauma or prior surgery. He's not on any regular medications. On examination, shows marked conjunctival injection with a crescent-shaped peripheral corneal ulcer extending from 5 to 9 o'clock, with undermined edges and adjacent stromal thinning. There is minimal infiltrate and no scleral involvement, and the central cornea appears clear and the corneal sensation is normal. Now, this is typical case scenario for a case of Morin's ulcer, and also we will give the differential diagnosis of this disease. As you can see from the questions, what's the differential diagnosis, what's the features of this case support the diagnosis of Morin's ulcer, and what's the systemic investigation and how we can manage this case, and what's the role of steroids as systemic or topical, and what's the complication of Morin ulcers, and how Morin's ulcer differs from peripheral ulcerative keratitis. Now you can see that there are strong points in the scenario suggestive of Morin's ulcers. Number one, it is affecting males more than females, and it is more common unilateral than bilateral. And also the ulcer is undermining edge with thinning of the stroma and minimal stromal infiltrate, all this in favor of Morin's ulcer. And the most important point is that there is no scleral involvement. As you can see here, there is no scleral involvement. And this is very important diagnostic point, because other peripheral ulcerative keratitis due to autoimmune diseases is usually associated with, in about 40% of the cases, with scleritis. So absence of scleritis, very strong sign suggestive of Morin's ulcer. And also the absence of abnormality in the corneal sensation. This is to guide you that it is not due to viral keratitis. So we'll start step by step answering all these questions, and this is a very interesting case for Morin's ulcer. As you can see here, there is undermining edge with no staining. Usually there is no staining with fluorescein, but will be pooling of the fluorescein in this area, and the undermining of the ulcer is larger than what's visible or appears here. And as I said, there is no associated scleritis. So we'll start answering one by one. As you can see that the differential diagnosis, number one is Morin's ulcer, which is very strongly suggestive in this case. Another thing is a peripheral ulcerative keratitis, and which is usually secondary to autoimmune diseases. Now, peripheral ulcerative keratitis is a group of diseases. It is not a single disease. Usually this is a finding that you find a peripheral ulcerative keratitis, but it will not point you to the underlying disease. But the association with systemic underlying disease is very strong, especially rheumatoid arthritis, Wegener's granulomatosis, and even SLE. It can be associated or secondary to infectious peripheral corneal ulcers like bacterial or viral. Sometimes it is peripheral, or due to marginal keratitis due to staphylococcal hypersensitivity. As far as Terence marginal degeneration, this is not a keratitis. This is usually there is no inflammations, and this is a degenerative problem rather than keratitis, similar to the pellucid marginal degenerations, and also sclerokeratitis. Sometimes another differential diagnosis is sclerokeratitis. Now, what features in this case support the diagnosis of Morin's ulcer? As I said, the description, that's crescent shape. A crescent because it follows the limbus, so it will be a crescent in shape. Peripheral corneal ulcer with undermined edge, absence of scleral involvement, as I said, and lack of history of suggestive systemic diseases with minimal infiltrate and normal corneal sensation and no history of trauma or surgery. All these are in favor of Morin's ulcer. And what systemic investigation that we should perform? As I said, that Morin's ulcer is diagnosis of exclusion, that after you exclude all other causes of peripheral ulcerative keratitis, at that time you can say that this is a Morin's ulcer. Otherwise, you should do a battery of investigation to exclude other systemic causes like rheumatoid factor, ANA, anti-nuclear antibodies, ESR, CRP, also syphilis serology, chest X-ray for sarcoidosis, and the reason for that to exclude any associated autoimmune diseases associated with vasculitis or angiopathies. So as you can see, Morris ulcer is a crescent-shaped peripheral ulcer with undermined edge, overhanging lips, with intrastromal yellowish-white infiltrate, circumferential, and usually tend to extend centrally and peripherally. This is another important point. Now we come to the fourth question. As far as the management of this case, of course, this is one of the ocular emergency, and admission to the hospital is mandatory in these cases, and start with lubricants and antibiotics, and try to avoid topical corticosteroids in these cases, because the use of topical steroids may complicate the picture, because steroids dramatically increase the risk of corneal melting and prevent the synthesis of collagen and prevent the function of fibroblast. So it is advisable to start with systemic steroids, provided there is no contraindication for steroids for the patients. If there is no improvement, we can jump to the more stronger systemic immunosuppressive drugs, either the cytotoxic drugs like the methotrexate, cyclophosphamide, azathioprine, or the other immunomodulators like the cyclosporine and tacrolimus. And sometimes in advanced and severe cases with visual threatening complications, the biological immunomodulators like flixizumab can be used as monoclonal antibodies that modulate the components of the immune system. Sometimes also we do surgical intervention in the form of conjunctival resection. As you can see here, there is resection of the conjunctiva from this area by 3 to 4 millimeter, and this helps to prevent the flow of mediators of the inflammation from the conjunctival blood vessels. Also, amniotic membrane implantation in this area can be helpful in augmenting the healing of the corneal ulcer, as well as eliminate the or reduce the inflammations. So this is the spectrum of the management of this case, and keeping in your mind that if this case is not managed properly, the risk of perforation complications is there with secondary superadded infection, and even if healing takes place, there will be extensive fibrosis and extensive astigmatism that affect the quality of vision of this patient. So this is the mainstay of treatment of these patients, starting from systemic steroids and ending up with biological immunomodulators. Try to avoid topical steroids as well as topical anti-inflammatory like the prostaglandin inhibitors like the diclofenac and indomethacin. All of these are useless. Better to start immediately with systemic steroids and monitor the response. If there is no improvement within 1 week, you have to go for more stronger immunosuppressive drugs. Now, the other question is regarding this case, which is for a 45 years old male patient presented with a fleshy triangular shaped lesion on the nasal side of his right eye, extending into the cornea. He works outdoors and in sunny environment. Now, the first question, what's your diagnosis? Of course, this is a very simple case, that this is a case of pterygium encroaching over the nasal side of the cornea, reaching up to the pupillary area. Now, the important thing is the other questions. That is the second question. What are the indications for surgical removal? Now, the indication for surgical removal of the pterygium is that when it is encroaching over the cornea, that strengthens the visual axis, or it induces a significant astigmatism that will affect the quality of vision of the patients, and if there is recurrence and severe irritation to the eye, and if there is fibrosis and restriction of the ocular motility. All these are the indications for the surgical interventions of pterygium. Of course, apart from the cosmetic indication, if the patient for cosmetic reasons he asks for removal of his pterygium. Now, the other question, what's the histopathology? Now, the histopathology for pterygium is elastic degeneration known as solar elastosis, also proliferation of the fibroblast and blood vessels, and squamous metaplasia for the surface epithelium of the conjunctiva. So all these are the pathogenesis, but mainly is the solar elastosis is the pathogenesis for
the pterygium. Now the other question, which are the surgical technique that's most effective and reducing the recurrence of the pterygium? Of course, there is many and plenty techniques for the pterygium removal, but the most well accepted and convincing now between doctors is the use of conjunctival autograft with limbal stem cells. This is very useful, especially from the superior bulbar conjunctiva, along with the limbal stem cells, that lowers the risk of recurrence and significantly more than 50%, especially if it is used in conjunction with the mitomycin. So this is the ideal way of excision of the pterygium, is the use of conjunctival autograft with limbal stem cells. Now the last question, what's the differential diagnosis of the pathology? You should know, you should be able to enumerate some of the important differential diagnosis of this pathology, especially those who have malignant potential. Now those which has malignant potential, now we have what's known as the ocular surface squamous neoplasia, abbreviated as OSSN. There are three main varieties: the leukoplakic one, which is white keratinized plaques often found in the limbus, as this one, or the gelatinous type, which appears as a circumscribed with hairpin shaped conjunctival blood vessels, as you can see here, or the one which is with papillomatous outgrowth, which is appears as exophytic growth, as you can see here. So you should be able to differentiate between pterygium and the ocular surface squamous neoplasia.
This is another case scenario for another patient who is 29 years old male with a refraction of plus 1.25 with a cylinder minus 2.5, and also he notes deterioration of his vision and intolerance to his glasses, and this patient is a good candidate for combined CXL with intracorneal rings. Now the discussion regarding whether to do the procedure combined together or sequentially, the pros and cons for each one technique is mentioned in my lecture regarding the cross-linking techniques and the intracorneal rings. We will not discuss this in details now, but this patient should undergo cross-linking as well as intracorneal rings to regularize the surface of the cornea and to provide another option for the patient who is intolerant to the glasses and the contact lens. The important points here that when we do the transposition, you can see that the cylindrical component is much more than the spherical component. So it means that we have to concentrate in the correction of astigmatism more than the sphere in these patients. And we have to choose a small arc length of the rings to concentrate on the astigmatism, as well as we have to use asymmetric rings to correct for this astigmatism. Now, the same procedure, we have to determine the site of the incision, which is the steep meridian, either on the clinical axis or the topographic axis. If they are coincided together within 30 degrees, we can choose an intermediate point between these two. In this patient, based on the Kmax, it is 36, the steep axis. However, based on the clinical axis, this is 20 degrees. So most likely we will choose a point between this 20 and 36 degrees to make our incision. And the rings will be straddle the flat meridian. Now, as I said, that we have to do both combined and cross-linking as well as intracorneal rings. Now, when you look to these patients, this is the steep axis, so the rings will be in these directions, and better to use asymmetric rings to correct for the astigmatism. So the inferior segment will be more thicker than the superior segment. Now, to sum up the discussion regarding the intracorneal rings, this is the criteria for intracorneal rings implantations: that the patient should be more than 18 years old and he's intolerant to the glasses or contact lenses. The corrected visual acuity is less than 0.6 and with good visual potential, so that with the use of contact lenses he will have more than 2 lines improvement in his visual acuity. A minimum pachymetry should be more than 400 microns. This is for the security of the tunnel, for the rings to be in the tunnel. And as you know, the rings should occupy 80% of the depth of the cornea. And there should be no scarring, no stria or voga stria or scarring in the cornea. And also we have to make sure that the alignment between the topographic axis and the keratometric axis. If not, we will center the rings on the coma axis, based on the parametry. There should be no pregnancy and no any other active ocular inflammations or active spring catarrh or autoimmune diseases. All these are contraindication for intracorneal rings. So to sum up, this is the general approach for the patient with intracorneal rings. We have to confirm the indication and exclude contraindications. We have to determine the steep X, as I explained earlier, either based on the clinical X, topographic X, or the coma X. We have to choose the ring type, whether to use the symmetrical rings or asymmetrical rings. You want to concentrate in the astigmatism or the spherical components. As you know, if the cone, based on also the location of your cone, if your cone is nipple cone, you can use symmetrical rings. If you have symmetric bow tie, you can use symmetrical rings. However, if you have asymmetric bow tie, you should use asymmetric rings. And the location of your cone should be based on the posterior flotation map, not in the tangential or curvature map. So all these points should be taken in consideration to determine the length of the segment and the width of the segment based on a special nomograms based on each type of rings you want to use, the Kera rings or the Ferrara rings or the Intex. Each one of these rings, they have its own nomogram. This is another interesting case scenario for a 40 years old patient presented with progressive decrease in his visual acuity over the last 2 years in the right eye, in spite of his using his spectacles, and he notes the significant glare and deterioration on his vision, so that affecting his daily activity. Now, you have given the tomography map for this patient showing the pachymetry of this patient and the steep X and the flat X of this patient. Clearly, it is shown there is a ferrotemporal steepening in the inferior part in the curvature map and small elevation in the anterior elevation map, and which is more pronounced in the posterior elevation map. And his pachymetry is reasonable, more than 500. Now, based on this information, we have to decide what other options that we can offer to the patients if he's intolerant to his glasses and contact lenses. And from the scenario that the case is progressing, so we have to discuss the possibility of doing cross-linking, although his age is 40 years old, which doesn't seems to be a good option for him to do cross-linking unless it is documented by otherwise firm tools. However, if we spare our discussion just on the other alternative options to improve the shape of the cornea of these patients, we will think on using the intracorneal rings. Now, we have to look out if there is any contraindication for intracorneal rings in these patients. And also we look to the indications of intracorneal rings. Now, first of all, his uncorrected visual acuity, as you can see here, is 660, which is a good indication for these patients. And provided he has a good visual potential, that's the best corrected visual acuity or distant corrected visual acuity improves more than 2 lines. So in this patient, it improves to 6.9. So this is a good indication for intracorneal rings. The other parameter is the thickness of the cornea. As you can see, the thickness of the cornea of this patient is more than 500, around 520. So this is another good indication, and there is no contraindication actually. The other thing is the K reading. The steepest K reading, which is in this patient, is around the Kmax 54, so it is below the 60. So from the first glance, there is no contraindication of this patient, provided there is no other contraindication in the form of acute active inflammations in the eye or autoimmune diseases or pregnancy. All these are contraindications for intracorneal rings. So from the first look, this patient is a good candidate for intracorneal rings. Now we will look for the other parameters which is important in the management of this case, which is we have to determine the site of the location of the intracorneal rings. We have to determine whether we have to use symmetrical rings or asymmetrical rings, and whether to use single piece or I mean 1 pair or 2 pairs of the intracorneal rings. Now, to determine the site of the incision, we have to convert or transpose the refraction of the patients to the positive cylinder to determine the X of of the incision, so that we determine the steep axis. Now, here there are different points. Now, if the refractive axis or the clinical axis coincides with the topographic axis plus minus 30 degree, so we can choose the incision site to be in between these two axes, so that we will correct the astigmatism as well as the spherical component of the patients. Now, if the cornea is completely irregular and we have the the steep axis, I mean of the clinical axis, and the topographic axis are not concise to each other, so we can go for the coma axis. We have to do a parametry for the patient and determine the high order aberration. Most commonly he will suffer from vertical coma, and determine the axis of this coma, and we do the rings based on the coma axis to regularize the surface of the cornea, so that we will improve the high order aberrations of the patient. So we have to do this. First step is very important. Now, as you know, the refractive axis, if you are reliable about your refraction, so that you can go with the refractive axis, provided that the topographic axis and the clinical axis are concise to each other. Now, the other thing that we have to look for the spherical components and the astigmatism in his refraction. Now, in this case, the spherical component is much more than the astigmatism, so we have to use two segments so that we will affect the sphere more than the astigmatism in this patient. So as you can see in this patient, the sphere is high, so we will use two segments. And from the topography, you can see this is the steep axis of the patients, so that the cylindrical axis is 140 degree. So most likely the incision side will be between 126 and 140. And since the bachymetry is 520, so there is enough thickness of the cornea to run the intracorneal rings. Now, the Kmax is not high, that's 54. There is no contraindication for these patients, so this is a good case for intracorneal rings. Now, the other thing, should we go for single ring or symmetrical rings or asymmetrical rings? The answer for this question based on the location of your apex of the cone. Now, if you have a nipple cone that's located within 3 to 5 millimeters from the center of the cornea, like in this case, so you can go for symmetrical cones. However, if the apex of the cone on the posterior flotation map, you have to go to the posterior flotation map. If it is decentered beyond the 5 millimeters, so at that time you can use asymmetric rings. So you have to look carefully to the posterior flotation map, determine your location of your apex of your cone, and accordingly decide to use one ring, or symmetrical rings or asymmetrical rings. In our case, this is a nipple cone located within 3 to 5 millimeters from the center of the cornea, so better to go for symmetrical rings. And this is the incision side, so the rings will be like this in each side to straddle the steep meridian. This is the steep meridian, and this is the flat meridian. This is another case scenario for a 38 years old male patient, presents with a slowly progressive blurring of vision and increasing astigmatism in both eyes over the past several years. He denies any pain, redness or photophobia, and there is no significant past ocular or systemic history. On a slit lamp examination, both eyes shows a superior peripheral band of thinning and yellowish white lipid deposition near to the limbus, with intact overlying epithelium and superficial vascularization. The corneal stroma adjacent to the thinning appears normal, and there is no ulceration or significant inflammation. Now, I think this is a very straightforward case for a Terence marginal degeneration. The points in the history in favor of this diagnosis that the patient presented with a slowly progressive deterioration of vision with increasing astigmatism, and there is no any pain or signs of inflammation either by history or by slit lamp examination. And the location of the thinning of the cornea appears on the far periphery in the superior part as a small band or furrow, and also the presence of yellowish deposits. Also, all these points are in favor of Terence marginal degenerations. So by looking to the picture of these patients, you can see this is the white lipids, yellowish white lipid deposition is seen in the superior part of the cornea, and in corneal topography, a clear cut against the rule astigmatism with sometimes irregular astigmatism. So this is a clear case of tearance marginal degeneration, as you can see here. This is another picture where the whole far periphery of the cornea is involved with yellowish-white deposition, and by slit lamp you can clearly see the thinning in the far periphery of the cornea. Now, there are a set of questions. By answering these questions, we can understand the nature of this disease, and you are ready to face any question from the examiner regarding this disease. So the provisional diagnosis is tearance marginal degenerations, and the supportive points, as I mentioned earlier. Now, let's come to answer this one by one. As I said, the diagnosis is tearance marginal degenerations. However, there are a set of differential diagnoses. The important points that it affects male patients, as you can note that most of the ectatic diseases affecting male patients. So, commonly affects male patients, either pellucid marginal degenerations, tearance marginal degenerations, keratoconus, keratoglobus, all of them, they affect male more than females. The bilateral nature of the disease with peripheral guttering or furrow present in the far periphery. An important point is intact epithelium. So there is no positive staining, and there is no ulcerations and no inflammations, with the yellowish deposits and progressive astigmatism and absence of pain. All these suggestive of tearance marginal degenerations. Sometimes they classify this type of diseases belong to the peripheral ulcerative keratitis. However, due to the absence of the inflammations and the indolent nature of the disease, it is regarded along with pellucid marginal degeneration. Both of them, they don't belong to the peripheral corneal ulcerations, but they belong to the peripheral corneal thinning or ectatic disease, because, as I said, there is no real ulcerations. Now, the important diagnostic tools that you have to apply to your patients is the OCT. Now, the OCT is very important to determine the nature of this thinning and the location of the thinning, as well as it is very important in the classification, as we will discuss later. Another thing is the epithelial mapping is very important to determine the thinning of the cornea and also the irregularity in the corneal epithelium. You should keep in your mind that this disease affecting the whole layers of the cornea, the epithelium will be abnormal and irregular. Also, the epidermis membrane will be abnormal. The stroma, there will be thinning of the stroma. The epithelium will show lipid deposition, intracellular and extracellular. And also, the descemet membrane might be ruptured, and the endothelium also might be abnormal. So this disease affects the whole layers of the cornea. It is not just the stromal thinning only. Now, the second question, what's the typical clinical course? As we have explained before, this is slowly progressive non-inflammatory disease with gradual worsening. The most important is the patient presented with irregular astigmatism or against the rule astigmatism. Rarely, around 15% of the cases, they will lead to perforation. So we should follow these patients very carefully, especially in young people, because there is two varieties of the disease. The one which is without inflammation, that's affecting the old people, and the one which is with inflammation that affect young people. I will explain about it later. So around 15% of the cases, they will have perforation. So you should follow them every 3 to 4 months and interfere accordingly if there is a significant risk for perforation or threatening the vision. Now, what's the provisional diagnosis that support this answer, or what's the differential diagnosis? As I said, it belongs to some, they classify them that they belong to the peripheral ulceration. However, there is no real ulcer, but they always come in the differential diagnosis with Morin's ulcer, in which there is pain and inflammations and ulcerations. By the way, Morin's ulcer also is more common in males as compared to females. Pellucid marginal degeneration, peripheral ulcerative keratitis, which is inflammatory, and marginal keratitis if it is due to infection or due to hypersensitivity to Staphylococcus aureus. Now, what's the indication for the surgical intervention in these patients? As I said, that there are two varieties. The classical variant time without inflammation, which is more common in old people and usually asymptomatic and slowly progressive. And there is another variant which is associated with inflammation that affects young people and is associated with inflammation, which can be seen clearly by OCT. When you find hyper reflective stroma, this is indicate that there is inflammation. So how you determine that there is inflammation, either clinically by your slit lamp or by the OCT. When you look to the stroma, you will not find them black, but you will find it hyperreflective. This indicates that there is inflammation, and this type can be associated with some autoimmune diseases. Now, like this type, this one slowly progressive guttering and peripheral thinning of the peripheral cornea with minimum inflammation. So this is the type which is affecting the old people more than 40 years old. So this is carries less risk of perforation as the other variants. Now the indication for surgical intervention, as I said, when there is a threatening of the visual function, or there is impending perforations or significant irregular astigmatism that make the patient intolerant to the contact lens. At that time, we have to interfere surgically. The surgical options ranges from lamellar crescent patch graft or lamellar keratoplasty. Sometimes, rarely, we do full thickness penetrating keratoplasty because usually the central cornea is normal, unless very rarely the central part can be affected, as we can see in the staging using the OCT. Also, the use of tissue adhesives for small perforations and amniotic membrane transplantation. Of course, this is apart from the use of lubricants and sometimes protective bandage contact lenses to support the cornea, and prevention of rubbing of the eyes. Your instruction to the patient to stop rubbing of his eyes. So thinning of the peripheral cornea with corneal opacification, neovascularization, and possible positive fluorescein staining are typical signs of the inflammatory type. As I said, that usually there is no staining, no ulceration, but in advanced diseases, you will find staining and loss of the epithelium and neovascularization of the peripheral part of the cornea. So this is indicative of the inflammatory variant, and you should be more careful about these patients. Now, an important question that you might be asked by the examiner, which is what's known as OCT staging of Terence marginal degeneration. This is a recent one based on the Wang et al. Staging system, based on the two parameters, that's the curvature of the cornea, anterior and posterior surface, as well as the pachymetry. So stage 1 completely normal. Stage 2, you have only concavity of the anterior surface of the cornea, but the posterior surface is normal with mild thinning of the cornea. And stage 3, you find the anterior surface is concave with a start bowing forward of the posterior surface and marked more thinning of the cornea. Then stage 4, the concave surface start to become bulging forward. So first it becomes normal, then it will bow forward, then finally you will reach to the perforation with maximum thinning of the cornea. So at these stages, you should be very careful and deal with your patient seriously with regular follow-up using the OCT, so that you prevent any risk of complications. This is another interesting case scenario for a patient who is completely healthy and doesn't have any visual complaints, and on routine examination presented with this corneal picture. He denied any history of pain or any blinding of vision, and the only positive history that he gave history of chronic use of amiodarone for cardiac arrhythmias. And on examination, his visual acuity is 6.6, no redness, no pain, nothing. Now, this is one of the most famous corneal slides and pictures that most of the examiners, they like to show them to the candidate, and they start the discussion regarding the differential diagnosis as well as what other parts of the examination that you have to do. So you should keep this in your mind. Of course, this is a case of vortex keratopathy due to the use of amiodarone. Now, the important thing regarding this case that you should know the definition. The vortex keratopathy, or the cornea verticulata, is a golden water-like deposition seen in the corneal epithelium, and usually involve the central part and the inferior part. This is just an exception that's involving the upper part. And to memorize them, it is as A, B, C, D, E, F. A stands for arthritis, commonly associated with diclofenac or indomethacin. B for breast cancer, commonly associated with tamoxifen, and the most popular drug, that's amiodarone in cardiac diseases. And D stands for dementia, chlorpromazine. And E stands for enzyme deficiency. That's the one for Fabry's disease, that is alpha galactosidase A deficiency. So to memorize them as A, B, C, D, E, F. The appearance, as I said here, it's a golden brown, gray, white lines involving the inferior and central part of the cornea. and is best seen by a slit lamp, especially by retro illumination, and usually patient is asymptomatic. Now there are other drugs that can be associated with this vortex keratopathy is the use of indomethacin, as I said, and suramine, that's for as an anti-parasite. You should be prepared for the differential diagnosis of the vortex keratopathy. As the picture, you can see in the picture, two important differential diagnoses, which is the crystalline keratopathy. Crystalline keratopathy, there are infectious causes and non-infectious causes. The infectious causes commonly in a chronically debilitated cornea with use of immunosuppression, usually due to streptococcus viridans, as in long-standing use of steroids in keratoplasty. And also this is another picture for crystalline keratopathy. Now the other differential diagnosis, which is the perineuritis, as you can see in acanthamoeba keratitis. If you are faced with this picture, also you might be confused for cornea verticulata, but of course the clinical history of the patient of severe pain and history of trauma by vegetative objects, all of these are in favor of acanthamoeba keratitis. So you should know about the crystalline keratopathy and radial keratoneuritis as a differential diagnosis. And for crystalline keratopathy is usually associated with sometimes with lens changes and also retinal changes, so you should keep them, and this is important why we want to do another examination for this patient apart from the cornea, that we have to examine the fundus, which is very important for you to mention this to the examiner when he asks you what other structure that you want to examine in this patient with cornea verticulata. You should immediately say that I would like to examine the posterior segment for seeing the disc swelling or atrophy, if there is due to tamoxifen toxicity, so there might be some disc swelling and atrophy. Also the presence of crystalline retinopathy due to also tamoxifen can be presented like this, or if the patient is using chloroquine, you might find pulse eye maculopathy as this one. This is crystalline retinopathy, or sometimes pseudoretinitis pigmentosa can be seen in patients with long-standing chlorpromazine. So it is very important that when the examiner asks you what are the other parts of examination you want to do, you should mention this differential diagnosis, that is the crystalline retinopathy and pulse eye maculopathy, and you want to examine the fundus.
This is another interesting case scenario for a 60 years old, 2 years old male patient with a history of Fox endothelial dystrophy, underwent a penetrating keratoplasty 2 years ago, and he's on low steroid therapy. Suddenly he developed metastatic cancer of the lung and received one of the anti-cancer drugs, that is pembrolizumab, as immune checkpoint inhibitor 3 months ago. He presented with a sudden decrease of vision and redness and mild discomfort in the right eye. Now his examination is a drop in the visual acuity to counting finger with ciliary injection and diffuse corneal edema, keratic precipitates in the endothelium and coda dust lines, and anterior chamber reaction with hazy graft. Now, what's your differential diagnosis? What's the most likely cause of this presentation, and how you are going to manage this case? Now, from this case scenario, you can clearly recognize that he has an acute attack of rejection, endothelial rejection, manifested by the coda dust line and reaction in the anterior chamber reaction and haziness of the graft. The problem that he was stable under the steroid control, and once he received this medication, which is known as immune checkpoint inhibitor, this is pembrolizumab, used for cancer, lung cancer. This medication induces the immune response to attack the cancer cells, but at the same time, the immune system will attack the endothelial cells of the allogenic graft. So this is the reason the patient has sustained an acute attack of rejection due to this drug. So the diagnosis is endothelial corneal graft rejection induced by pembrolizumab. This is the drug. As I said, this is used in lung cancer. And to understand about this drug, which is known as a immune checkpoint inhibitor, refers to a class of drugs used in cancer treatment that unblock the immune system so that it will attack the cancer cells. Now, the most likely cause, as I said, this is due to induction of the immune system by this drug that boosts the function of the T cells activity that will attack the tumor cells as well as the allogenic graft. Now, what's the immediate management for this patient? You can deal with him as an acute emergency with topical high dose of steroids and systemic steroids, and possibly temporarily suspend the pembrolizumab for a while. You need to discuss with the treating doctor for this cancer, and topical cycloplegic drugs to relieve the pain once the acute attack subsided. So you can discuss with the treating doctor to change the medication or and assess the prognosis and the severity of the lung cancer. The next case scenario for a 45 years old farmer who presented with acute red eye and photophobia following an trauma with a vegetative manner. And on a clinical examination, you can see this is the feathery appearance and with feathery margins and scattered satellite lesions in the cornea with hypopyon. And from this case scenario, most likely this is a fungal keratitis. This is the corneal scraping, shows the hyphae. This is most likely due to Aspergillus fumigatus, as we have said before in the lecture of fungal keratitis, which is divided into a hyphae like Fusarium and Aspergillus fumigatus, or as a yeasts like the Candida albicans, or dimorphic fungi. Now, this corneal scrape is characteristic of septated hyphae, that is Aspergillus fumigatus. And another point, as you can see, the hypopyon here is straight and forming a level. This indicates that this hypopyon is due to the reaction and is not due to active invasion of the fungus inside the eye, because usually the hypopyon and fungal keratitis is not sterile due to active invasion of the fungus inside the eye, but at that time you will find the hypopyon has pyramidal shape because of adhesions and is not respecting the position of the eye. However, when you find the hypopyon shows a level like this and there is no pyramidal appearance, so this is not most likely is a reactive hypopyon, is not due to active invasion of the hypopyon of the fungus itself. So the question here is, what's the most common causative organism, and of course what will be the workup and the management of this case. As far as the management of the fungal keratitis, there are certain important points we should consider before we start the management, because when you refer to my lecture regarding the management of infectious keratitis, namely the mycotic keratitis, there are certain important points regarding the presence or absence of ulcer and the size of the ulcers, and also if this there is infiltrative hypopyon or not. So after doing the corneal scraping, direct microscopy and culture in the proper media, and you confirm the diagnosis of, for example, Aspergillus keratitis, now the treatment regime is as monotherapy if the ulcer is less than 5 millimeter and there is no hypopyon, so monotherapy is advised. But in this case, as you can see that there is hypopyon, so monotherapy is not ideal for this case. It should be a combination therapy that I will explain later on. Generally, for Aspergillus fumigatus, monotherapy with natamycin is the first line, and alternatively we can use the voriconazole. And it is preferably that if the case is due to fusarium, so voriconazole is not that effective against fusarium, so preferably to start with natamycin. However, we can use voriconazole as a systemic combination rather than topical drops in fusarium, as this is advised by the MUT study that I will explain about it later on. Now, of course, the adjuvant therapy along with the cycloplegia and other systemic antifungal drugs can be used, but there are certain indications for this systemic antifungal. Now, as I said, that this is from my lecture of the infectious keratitis, that for a monotherapy, if you have a superficial ulcer less than 5 millimeter with at least 1/3 depth of this corneal infiltrate with no hypopyon. In these cases, monotherapy is advised, as I said, in the form of natamycin eye drops half hourly for 24 hours, or you can use amphotericin drops, especially effective against Aspergillus, or voriconazole. However, The other adjuvant therapy, as cycloplegia and antibiotic in the presence of superadded infection, can be used. Now, depending on the response and the dose, the combination therapy will be. Now, if there is no response after a few weeks, at that time we can shift to the combination therapy. Or if there is a ulcer more than 5 millimeter and the depth is more 1/3 and there is hypopyon, at that time we have to go to the combination therapy. Now, the important point is the role of debridement. Now, in these cases, debridement is very important in fungal keratitis, especially in the metaceous fungi. Nearly daily, the patient come for you, you have to do debridement. The debridement will serve as a debulking for the microbial load present in the cornea, as well as it facilitates the penetration of the topical antifungal drugs, because as you know, the exudates and the secretions will limit the penetration of the antifungal. So debridement is very important in fungal keratitis. And as far as the combination therapy, as I said, the indication before, if it is more than 5 millimeter single-eyed patient, deep ulcer with presence of severe hypopyon, in these cases with endothelial plaques, we have to shift to the combination therapy. Or if there is failure of the monotherapy for more than 2 weeks, at that time we have to shift to the combination therapy. And when we say combination therapy, that we use the natamycin along with voriconazole, or we can use the natamycin with amphotericin. Now, the combination of amphotericin and natamycin is not advised because they belong to the same group, that's the polyene group, so they have no synergistic action. Combination therapy, either use the natamycin with voriconazole or use amphotericin with amphotericin with voriconazole. The combination of amphotericin and natamycin is not advised because they belong to the same group. I suggest for you refer to my lecture in infectious keratitis regarding the management of fungal keratitis, so that you are prepared for any questions. Another important thing that you should be prepared for the question or discussion regarding the MUT trial. There is MUT1 and MUT2. The MUT1 regarding the topical application of natamycin versus topical voriconazole. As I said, that there is no difference between natamycin and voriconazole as far as the initial line of treatment for monotherapy. Unless you suspect strongly that the infection is due to fusarium, so that at that time voriconazole is not advised to be used as a monotherapy in filamentary keratitis due to fusarium, because it is not that effective against fusarium. So you should use natamycin. Otherwise, there are other fungi. There is no difference between fusarium and voriconazole and natamycin. Now, for the MUT study 2, it compares the topical applications of natamycin plus voriconazole plus minus the addition of systemic antifungal. The same thing that the addition of oral antifungal did not decrease the rate of perforation or the need for therapeutic keratoplasty. They found it. However, in the fusarium keratitis may benefit from addition of oral voriconazole to topical natamycin. So this is the only indication in the presence of fusarium. So because of fusarium, you might lose the eye within a few days. It will present with severe fulminant infection that completely destroy the cornea within a few days. These are the doses for the systemic applications, and the indication for systemic antifungal if you suspect fusarium keratitis. This is another interesting case scenario for a 58 years old male patient presented with a blurring of vision in the right eye with the progressive drop of the vision over the last year, and he gave a history of LASIK procedure 10 years back, but unfortunately there is no any preoperative data as far as the tomography or the keratometry. Now his right eye has nuclear sclerotic cataract with the visual acuity of 660, improved to 618 with pinhole, and on examination the visible LASIK flap is there. Now on examination, the right eye, as I said, 660 improved to 618 with pinhole, nuclear sclerotic cataract, and no corneal scarring, only LASIK flap is there. Now the refraction or the biometry done for this patient using a special formula that is known as no history Higias L formula for IOL calculation that doesn't need pre-LASIK data.
and the IOL power came up to be 19 diopter monofocal lens. Surgery done and the IOL implanted, and unfortunately after 1 month the patient came back with poor vision, and upon refraction he was found to have a +3 diopter of hyperopia. So there was an error in the IOL calculation because of the problem of the prior LASIK procedure, and now he is not happy and complaining of this hyperopic shift that happens after IOL calculation. So this is a very interesting case scenario, and you might be asked by the examiner that the aim of this scenario is to be aware how to deal with a patient with a prior history of refractive surgery, either LASIK or PRK, and how to choose the proper IOL formula to estimate his power, provided that he has no pre-LASIK or pre-PRK data as far as the keratometry. And as you know, absence of these data are very crucial and very important, and this might expose to the patient to the hyperopic shift that expected after myopic LASIK correction. Now the questions for this scenario is, what are the main challenging for IOL calculation in this patient? What specific formula or calculation strategies would you like to use, and how to manage this refractive surprises of hyperopic shift of this patient, and how will you calculate you correct the error that happens in this patient after the wrong calculation, and what are the explanation for this hyperopic shift for this patient. This is the IOL Master Zeiss 700 biometry printout. As you can see, this is the axial length as it is measured, and this is the keratometric, the standard K1 and K2, and also what's known as the TK, that's the total keratometry value. So we will tackle this case step by step and try to understand all the different scenarios and all the questions that the examiner might ask you about this case. Now, first of all, what are the challenging points in this case? As I said, that the challenging point in the IOL calculation in this case is due to the prior LASIK surgery. As you know, in the standard biometry techniques, they measure the total power of the cornea based on the power of the anterior surface, and based on fixed ratio and fixed index, they estimate the power of the posterior surface of the cornea. So this is the source of error, because now the fixed ratio between the anterior and posterior surface is altered by LASIK. So there will be an overestimation of the power of the cornea, and this overestimation of the power of the cornea will lead to underestimation of the power of the IOL and lead to a subsequent hyperopic shift that is expected in patient after LASIK correction. So the main challenging point is due to the reliance on the fixed ratio of estimation of the power of the posterior surface of the cornea. That's why the recently advanced IOL formula incorporate the artificial intelligence and take in consideration the accurate direct measurement of both of the anterior and posterior surface, and avoiding the estimation that's based on the fixed index, which is usually 1.2. That's the posterior surface is more curved than the anterior surface. So by direct measurement of both anterior and posterior surface, we can overcome this problem. So this is bring us to talk about what's meant by total keratometry. Now the recent machine, especially the IOL Master Zeiss 500, utilizes the new principle of TK, that's the total keratometric measurements. It means that we measure the anterior corneal curvature using the telecentric keratometry, and we measure also the posterior corneal curvature using the swept source OCT as a factor related to the corneal thickness. So the TK uses the thick lens formula to integrate these measurements and provide more complete and accurate estimation of the total power of the cornea as compared to the traditional way of biometry. So it will provide improved correlation with the true refractive power of the cornea, and better prediction with modern formula, and useful when historical data is missing. Now this is example of the IOL calculator, which is present online, that you feed it with the patient's data, and it will ask you for the patient, as far as the patient with myopic laser, prior myopic laser or PRK correction, to use the TK
value. Now the TK value is available when you are using the either the IOL Master 500 updated version, or they use the IOL Master 700. So to overcome the problem of prior laser correction, you should rely on the TK value rather than the traditional keratometric value, because this TK based IOL calculation significantly reduces the risk of refractive surprises and improves the likelihood of achieving the desired post-operative outcomes, especially in both LASIK and post PRK cases without prior clinical history. So this is in one aspect, and in the next discussion we'll discuss about the different formulas that is ideal for such scenario, and how we deal with the case of hyperopic shifts. Now the recommended IOL formula for such case is that we use the modern formula, most likely that's known as the Parrot True K with no history, or the Hagias L, or the Shams PL formula, or the online Ascaris calculator. These are useful IOL formula that is used based on the without prior history, so we can use this formula for accurately predicting the IOL power and the effective lens position in patients with prior LASIK or PRK surgery. So this is very important, the Parrot True K. Now the True K is the keratometric readings of the patients after LASIK correction. Also, this is a little bit more accurate than the traditional K, but it is to some extent more accurate than the traditional biometry K reading. However, the ideal is to use the what's known as the total keratometry. Now the total keratometry differs than the True K. The True K, it measures the anterior surface of the cornea but estimates the posterior surface of the cornea. However, the total keratometry, it measures both the anterior and posterior surface of the cornea based on the telecentric principle of the anterior surface of the cornea and the swept source OCT for the posterior surface of the cornea. So you have these options: either use the True K for the Parrot formula, or Hagias L formula, or Shamas PL formula, or the line calculator, or preferably, if you have the IOL Master 700, to use the TK based formula, which is like the Hagias formula with TK, or Parrot True K TK formula is also available. So in summary, these are the different formulas that you can use. As I said, either based on the True K or based on the TK. All of them are very reliable, and it is advised to carry out the calculation with more than one formula, and so that you choose the one which brings you to the myopic side of the patients. So at that time it will be more accurate and more precise. Not that you take the average of the power, but you use the 3 or 4 formulas so that you know what the proper that you are in the proper figure of the IOL, and try to choose the IOL power that brings your patient to the myopic side. This is the picture, as I said, for the online IOL calculator for patients with post LASIK. Now, to explain why this hyperopic shift has happened in this patient, the first explanation could be in the presence of dense cataract. The the optical biometry sometimes is not accurate in the measurement of the axial length of the eye in the presence of dense cataract. Another thing in the scenario, as you know, that they use the Hagias L formula, which is designed for both LASIK eyes, but without historical data, it can still have some error of overestimating the corneal power, especially in high myopic patients, and this can lead to the overestimation of the power of the cornea, will lead to the underestimation of the power of the IOL, and lead to the hyperopic shift and the refractive surprises. The other thing that they don't use the total K as we have said earlier, so preferably in such scenario to depend on the TK dependent formula. All these could explain why this hyperopic shift has happened in this patient. Now let's discuss about the management of this hyperopic shift. Start with the first simple way of correcting this hyperopic shift by using the glasses or the contact lenses. And if there is any corneal reserve, we can do a LASIK correction for this patient for this hyperopic shift, provided that there is a corneal reserve that permits this type of surgery. The advantage of this types is that non-invasive as compared to the other option, which is the surgical IOL exchange, especially if the patient discovered immediately after surgery. But if, like in our scenario, the patient come after 2 months from the surgery, so the only option is to, and there is no chance for doing LASIK for him, is to do the piggyback IOL, secondary IOL implantations. And this is also requires special consideration that we have to measure again the IOL that he needs, and based on a special calculation we can expect or measure how much the needed power of IOL that we can add to this patients. There is a fixed formula usually based on the power of the residual hyperopia which is present at the spectacle plane, and based on that power we can estimate how much extra power he need to be implanted in the sulcus. So we need to remeasure again the axial length and determine the error, and compare the power of the IOL that's implanted already and the power of the IOL that should be implanted, and by subtracting the difference between these two powers we can expect or estimate how much the power of the piggyback IOL to be implanted. So this is very important to verify the axial length again and measure your patients again, and in the presence of dense cataract preferably to use the immersion technique rather than the optical biometry. And for no history regarding a prior LASIK surgery, better to rely on the TK dependent IOL formulas. Now the advantage, as I said, and the pros and cons of the spectacle and contact lenses, that is no surgical intervention again, but the disadvantage sometimes is not satisfactory to the patients. IOL exchange requires skills of the surgeon, and be careful not to rupture the posterior capsule. Piggyback IOL is the only option if the patient came after a long time, and corneal refractive surgery is less invasive, but it requires a good corneal reserve to perform this procedure. This is another case scenario of a 28 years old male patient complaining of progressive blurring of vision in both eyes that worsen at night, and with difficulty in wearing the contact lens due to comfort in his eyes. On examination, visual acuity in the right eye was 20/60 and left eye 20/40, and without the use of the contact lenses the vision is 20/80 and 20/50. Now, the most important thing that on a slit lamp examination, we discovered that the patient has bilateral generalized corneal thinning with a globular protrusion more pronounced in the periphery, and a clear cornea in the center, no scarring, no vascularization or acute hydrops. And on corneal topography, there was severe irregular astigmatism with generalized steepening more than 58 Kmax in the right eye and 59 in the left eye, with severely thin cornea reaching up to 380 microns in the right eye and 370 microns in the left eye. So this is the case scenario, and I think it is easy for you to pick up the diagnosis. What's your spot diagnosis and your differential diagnosis? From the picture you can see this is a very clear case of keratoglobus, and as you can see the topography, this is a special color that you rarely see this color in severe steepening of the cornea that even bypass and surpass the red color that we used to see in keratoconus. And as you can see, this is the OCT. The thinning is maximum in the mid periphery with forward bulging of the cornea, and the thickness in the cornea is good, but the thinning much more in the far or mid periphery. So this is a case of keratoglobus clear cut. Now the importance for us is what's the differential diagnosis of this case. Now the differential diagnosis, as any ectatic disorders, there are three or main important differential diagnoses. In the top is the keratoconus. Another differential diagnosis is pellucid marginal degenerations, and then posterior keratoconus. And so these are the main differential diagnoses that we have to distinguish between them. Now, first of all, the main differentiating points in the keratoconus, that's keratoconus is a localized disease, usually associated with thinning in the inferior part, inferior central part of the cornea, and is associated with bulging of the central or paracentral part of the cornea. So it is a focal disease which mainly involve the thinning and the bulging in the central and paracentral part of the cornea, with some other signs like Fleischer's rings and Vogel's stria, unlike the keratoglobus, which shows generalized thinning in the cornea, which is maximum at the mid-periphery. Another thing, the pellucid marginal degeneration also belongs to the one of the ectatic diseases that usually characterized by crescent-shaped thinning, and this crescent shape also is present in the mid-periphery, especially in the inferior part, rarely in the superior part of the cornea, and usually the bulging will appear on the above the thinning part of the cornea. Unlike in keratoconus, the bulging which appears within the thin cornea. However, in pellucid marginal degeneration, the bulging of the cornea will be above the thinning part, that's the thinning crescent. In posterior keratoconus, you will find just localized elevation in the posterior surface of the cornea, which is commonly seen by topography and can be seen also by anterior segment OCT. So these are the main three differential diagnoses for this case. I will explain in the details how to compare between keratoconus and pellucid marginal, keratoglobus. As I said, in keratoconus, both of them they are associated with ectasia and bulging of the cornea, but they are not belong to the same disease. They are a separate entity. This is an important thing to understand, that keratoconus is a separate entity than keratoglobus, although they have a similar presentation, that's thinning and bulging of the cornea, but they are completely separate diseases. So the thinning in the cornea in the keratoconus is usually in the central and paracentral part, and the cone in the central or paracentral area of the cornea. However, in the keratoglobus, there is diffuse generalized thinning, and bulging the whole cornea is bulging. Now, as far as the keratoconus, as we support the evidence that they are separate entity, there are different theories behind the etiology, most likely due to enzymatic imbalance or mechanical trauma to the cornea, that it initiates a circle of decompensation of the corneal biomechanics. This is called cycle of decompensation of corneal biomechanics, end up with the bulging of the central or paracentral part of the cornea. However, in keratoglobus, it is circumferential all over thinning of the cornea. It can be associated with collagen vascular diseases or collagen diseases, and can be congenital and usually associated with high risk of rupture, unlike in cases of keratoconus. Now, the genetics also plays important role in both of the diseases. However, keratoglobus can be sporadic, and as I said, it is commonly associated with collagen and connective tissue diseases like Ehlers-Danlos syndrome and blue sclera and Marfan syndrome. So if you have a patient with keratoglobus, you should investigate him thoroughly for these diseases. However, in keratoconus may associated with Down syndrome and Leber's congenital amaurosis. As far as the age presentation, the keratoconus is present a little bit late, between 10 to 20 years. However, in keratoglobus is much more earlier. It can be congenital, but the presentation usually earlier, and characterized by significant poor vision in childhood. As far as the appearance, as I said, that the cone in keratoconus usually in the central paracentral area, surrounded by a Fleischer's ring and Vogel's stria, presence of Manson signs, Caesar reflex retinoscopy. However, in keratoglobus, generalized globular protrusion of the entire cornea with diffuse thinning of the cornea, sometimes lead to spontaneous or rupture or due to precipitated by trauma. So the corneal thickness is usually not that much bad. It is less than 450 and can be reaching up to 400 and sometimes around this range. However, in keratoglobus, especially in advanced stages, as I will explain later, you will find even up to 200 and 300 microns thickness of the cornea. And topography shows steepening and bulging of the cornea just on the thin part of the cornea or in the inferonasal part of the cornea, with other regular types in the form of symmetric poti or asymmetric poti. However, in keratoglobus, there will be generalized bulging and severe irregular astigmatism can be seen in these cases. So what I want to emphasize that both keratoconus and keratoglobus are distinct separate diseases, not a variant of the same disease, although they have the similar representation, but they are completely different. Now, as far as the comparison between keratoconus and pellucid marginal degenerations,
Pellucid margin degeneration characterized by crescent-shaped thinning present in the mid-periphery between 4 to 8 o'clock, and usually the bulging of the cornea will appear above this crescent. That's why it gives the characteristic kissing dove appearance in corneal topography, and the severe against the rule astigmatism that's seen in pellucid marginal degeneration. However, in keratoconus, it will give rise to an irregular astigmatism. The other thing that same thing, they are separate entity, separate diseases, although they have a common presentation, and sometimes keratoconus will present like pellucid marginal degeneration in a variety called pellucid-like keratoconus, but based on the history of the patients and based on the appearance and topography, we can differentiate between keratoconus and pellucid marginal degeneration. Now we will answer the questions one by one. After we have knew the diagnosis that it's keratoglobus, what's the non-surgical management options would you recommend for this patient? Of course, the non-surgical options are many. And the top is the use of rigid gas permeable contact lenses to improve the visual acuity and also to improve the surface and neutralize the high degree of astigmatism. Also, the use of scleral contact lenses may be preferable than rigid gas permeable, because sometimes in severe keratoglobus the stability of these lenses will be an issue, and the use of scleral contact lenses will be a better options. Of course, close monitoring of these cases are very important because they are at high risk of perforations more than cases of keratoconus. And the other options which is available apart from the medical conservative options is the surgical interventions. There are a set of different surgical interventions, starting from large diameter penetrating keratoplasty, so that based on the degree and the extension of thinning, we can decide the size of the button that we are going to use. Also, the use of deep lamellar stromal keratoplasty preferred when the endothelium is intact and there is some reasonable thickness in the cornea. Also, one of the famous procedures, which is known as limbal sparing lamellar keratoplasty, in which we do lamellar keratoplasty up to the limbus, but spare that part of the limbus that covers the limbal stem cells. This is abbreviated as LSLK. This is also another option. As you can see here in the OCT, this is the line of demarcation between the donor cornea and the recipient cornea. So this is lamellar keratoplasty, that we remove the corneal epithelium of the patients and remove the corneal endothelium from the donor cornea, and then we apply them together. Also rarely is not used nowadays is the use of epikeratoplasty and what's known as the tuck procedure, tucking of the pattern of the corneal donor cornea by creating a gutter in the far periphery after removing the corneal epithelium, and we try to tailor that part of the pattern of the cornea inside that gutter so that it will secure its place. This is the most common surgical interventions available, and for you as a student, you should be able to mention and discuss with your examiner regarding these options. Now, the last thing is what's available recently, which is known as the PACCXL, which stands for Pachymetry Assisted Accelerated AB-on Cross-Linking, invented by Hafizi et al. Group. And this is based on the principle of delivering high fluence energy guided by the pachymetry, and so that we can deliver the ultraviolet energy based on that part of the cornea which is thin and defective, because the principle of keratoconus, as we said, that there is focal defect in the corneal epithelium. Now in the next discussion, we'll discuss in details about this modality of treatment, and PACCXL represented as a revolution in the management of keratoconus. So you should be able to answer your examiner about this new invented technology. Now we come to the second generation of customized CXL, which also belong to the overall fourth generation CXL techniques. So it is a second generation because it utilizes a principle of concentration gradient for the riboflavin, as well as a profile gradient for the ultraviolet and using a second generation penetration enhancer. The idea is that we establish a riboflavin concentration gradient within the stroma by making a small window of PTK removal of the epithelium using the PTK based on the epithelial map. Now, based on this epithelial map, we can determine the apex of the cone, and just we remove the epithelium over that apex of the cone so that we create a small window in the epithelium. As you can see here, this is the small window. So this window will act as if a combination of both AB-on technique as well as AB-off technique. So we'll utilize the benefits of AB-off cross-linking and also the benefits of AB-on cross-linking. Now, after that, we apply the riboflavin so that the riboflavin, once applied, so there will be a concentration gradient because the penetration will be more, especially after utilizing a second generation penetration enhancer. So the penetration to the normal cornea will be less. However, the penetration over the area of AB-off will be more. And then there will be another intermediate zone of concentration gradient. So this is a gradient of riboflavin. As you know, riboflavin is in a direct proportional relationship with the effect of cross-linking, so that there will be a linear relationship for the cross-linking effect based on this concentration gradient. Similarly, once we apply the ultraviolet profile, which is special pulsed slow irradiance high fluence ultraviolet, so that the penetration of the ultraviolet over the window of the AB-off will be more, so this will exert more effect, and the penetration over the intermediate zone will be less because this is an AB-on, and also the penetration over the far periphery will be less. Another thing, the machine is already customized so that it will have special profiles based on the shape of the cone, so that the machine will be programmed by the software so that more energy will be delivered to this area and more energy, less energy to this area and less energy to this area. So we will have both a ultraviolet profile gradient as well as riboflavin concentration gradient. Both of them will act in such a way, in such customization, so that more effect will be on the steeper part of the cornea. So there will be more flattening in this area as compared to the periphery. So we will induce more both flattening as well as coupling effect, so that you will induce flattening in this area and steepening in that area. So this will lead to a marked improvement in the shape of the cornea, as well as also improvement in the visual function of the patient. They claim that up to 10 diopters can be improved in the Kmax by this technique, and the effect is very effective within the first 3 months. So as you can see here, this is some of the pictures of the topography patients before the PACE CXL, and this is after around 4 weeks after the PACE. You can see this is the difference map. So it is inducing a flattening in this area and also induces a steepening in the peripheral part. So this is the coupling effect. And now this coupling effect is not seen in LASIK. So we can induce both refractive changes as well as regularization of up to 12 diopters, as they say. So your patient will notice a significant improvement in his visual acuity, and this make the patients ready for any subsequent wavefront guided BRK later on, so that you preserve the cornea. You don't remove any part of the stroma, you just remove the epithelium that will heal later on. And when you induce up to 10 to 12 diopter of improvement, this will make your patient is ready for further customized ablation. So you will apply the two principles, customized CXL as well as customized ablations. And this is also open the door that we can apply this technique even in a patient with stable keratoconus. Not necessarily he has progressive keratoconus. As you know, the main indication of corneal cross-linking in the presence of progressive keratoconus. But because of the marked improvement in the refraction of the patients and improvement in the stability of the cornea as well as the shape of the cornea, we can use it even in a normal, in a keratoconus patient without any signs of progression, so that we will improve the quality of vision of this patient. Now, if you can see here the demarcation line by this way, so you can see that the deep demarcation line over the area of the cone
This is because of the deep concentration of the riboflavin as well as the ultraviolet. And the peripheral part of the cornea, which is the normal cornea, has superficial demarcation lines. So we only cross-link or induce the photochemical reaction of the cross-linking over the steep area, that's the apex of the cone. So in conclusion, the PACE offer a massive regularization of the shape of the cornea with improvement of the visual acuity without any removing of any tissues like in LASIK, and it can open the door for managing even non-progressive keratoconus and also help to stabilize progressive keratoconus.
This is another interesting case scenario for a patient with who is male, present with a progressive visual loss. Just I like to remind you that most of the ectatic diseases are common in males. So keep it in your mind. Pellucid marginal degeneration, Terence marginal degenerations, keratoconus, keratoglobus, all are common in males. Now, this patient complained of progressive drop of vision. As you can see by a slit lamp, he has significant thinning, mainly in a crescent-shaped 1 to 2 millimeter above the limbus, with a normal cornea between the limbus and the thin cornea. Topographically, you can see clearly the butterfly appearance on the sagittal map, or the kissing dove appearance, and significant thinning of the cornea around 420 microns. So this is characteristic of pellucid marginal degeneration. Now, the main important points that, number one, look to the sagittal map. You should see this picture of kissing dove or butterfly appearance, and this is called also kissing pigeon. This is on the sagittal map, and significant against the rule astigmatism. There must be an against the rule astigmatism. By slit lamp, you will find the crescent-shaped thinning in the far periphery, sparing the 1 to 2 millimeter from the limbus of a normal cornea. You have to have a large scale topography to look for the pachymetry. As you can see, this is the pill sign which is seen on the pachymetry. That's significant thinning all over the cornea from the central part up to the far periphery, sparing just a small band or zone of 1 to 2 millimeter of clear cornea. And as the name implies, pellucid indicates normal cornea. That there is no signs of inflammation, no hydrops, no vagus stria, no any other signs that's seen in keratoconus. So the diagnosis here is pellucid marginal degeneration. Nearly the management is not different than keratoconus, starting from conservative methods of rigid gas permeable contact lenses, scleral contact lenses. You can do sectorial or crescent shape lamellar keratoplasty, and also you might need to do cross-linking also for these patients. And finally, recently advanced is the femtosecond laser-assisted lamellar keratoplasty. Can be of a role in this type of corneas. As you can see that the thinning is the inferiorly sparing the upper part. But this is not all. Sometimes you'll find the thinning in the upper part in pellucid marginal degeneration. Another point that I would like to emphasize is the difference between pellucid marginal degenerations and keratoconus. And there is another entity which is more confusing, known as the keratoconus pellucid-like keratoconus, pellucid-like keratoconus. Now, if you follow the main steps, that's the pellucid marginal degeneration, you will see in the sagittal map the butterfly appearance. In the pachymetry map, you will see the pill sign, and you find severe against the rule astigmatism, more than 4 diopters, and a crescent-shaped corneal thinning inferiorly, and bulging of the cornea. You will find bulging of the cornea above the thinning part of the cornea. This is very important sign that you find the bulging first, and then the thin cornea is below it. However, in keratoconus, you will find both the thinning and the bulging coincides to each other, either in the central part or paracentral within 3 to 4 millimeter zone from the cornea. However, in pellucid marginal degeneration, you will find it in the far periphery. Sometimes and rarely, keratoconus will extend up to the far periphery, which is known as eccentric or ectopic cone. At that time, it makes a confusion with pellucid marginal degeneration, because the bulging and the thinning of the cornea is a little bit extended beyond the 3 to 4 millimeter central zone, but still preserving the far periphery is normal. So this may make confusion with pellucid marginal degeneration. And in these cases, you should go for other signs like the presence of vagus stria or the presence of Fletcher's ring. All are in favor of keratoconus. Now, why we are more interested to differentiate between pellucid and keratoconus? As I said earlier, both of them are separate entity, although they have a common manifestation of ectasia and bulging and irregular astigmatism. However, the presentation differs in keratoconus a little bit earlier as compared to pellucid marginal degenerations. But both of them, they are separate entity as far as the pathogenesis, and also the response to the corneal cross-linking. Keratoconus cases have a better response to the corneal cross-linking as compared to the pellucid marginal degeneration. At the end, at the advanced cases of both of these situations, penetrating keratoplasty might be needed or lamellar keratoplasty. So you should keep this differentiating point between keratoconus and pellucid, and keep in your mind what's known as pellucid-like keratoconus. All these points will impress your examiner when you reply to him regarding these differences, and you exhibit your competence in showing the difference topographically between these two separate entities. بهذا القدر نصل أعزائي الطلبة إلى نهاية هذه المحاضرة. تناولنا فيها العديد من السيناريوهات والproblem solving questions in different corneal diseases. As I said, that these problem solving are oriented for those who are willing to appear in the postgraduate exams, namely the Libyan board and the FRCS exams. I hope that you have benefited from this lecture, and I wish for you the best of luck for those who are going to appear in any postgraduate examination. Looking forward to meet you soon in another session and another lecture. For that time, I hope for you the peace and good of luck, and thank you very much for your audience.